The Ways and Means Committee will come to order. Good morning and a word of welcome. I'm delighted to see all of us back here in what I've always considered the best address on Capitol Hill, 1100 Longworth. We are holding today's hearings in a hybrid format in compliance with the rules and regulations for remote committee proceedings pursuant to House Resolution 8. Before we begin, I want to remind members of a few procedures to keep these proceedings running smoothly. First, consistent with regulations, the committee will keep microphones muted to limit background noise. Members are responsible for unmuting themselves when they seek recognition or when recognized for their 5 minutes. Committee staff will mute members only in the event of inadvertent background noise. In addition, when members are present in the proceeding via WebEx, they must have their cameras on. If you need to step away to attend another proceeding, please turn your camera off and audio off as well, rather than logging out of the platform. And now I will turn to the topic of today's hearing, substance use, suicide risk, and the American healthcare system. Exactly 1 month ago, we held the first hearing in a decade on examining America's mental health crisis. Our discussion underscored how multidimensional the issue is, touching on factors including gaps in healthcare coverage, stigma, structural inequities, and workforce supply. The COVID-19 pandemic only complicated and exacerbated this long-standing crisis, causing increases in social isolation, anxiety, and workforce burnout, all of which compounded and heightened existing collective mental health conditions. During today's hearing, we will take a deeper look at the interrelated mental health issues: substance use disorders, overdose deaths, and suicide. These are somber issues that affect each and every one of our communities. I was very pleased, and we were able in the 115th Congress to pass bipartisan support legislation called the Support Act, which made progress in combating the opiate crisis, including policies like adding opiate treatment programs to Medicare providers. While the legislation was a step in the right direction, data tragically show that more work must be done to help those who are indeed suffering. In 2020, more than 40 million people over the age of 12 struggled with a substance use disorder. That same year, as the COVID-19 pandemic cast its shadow over our nation, the United States set a record high 100,000 overdose deaths. Sadly, suicide rates also remain at historic levels. America has the highest suicide rate of any wealthy nation, nearly double the rate of the United Kingdom. During last month's hearing, we spoke about the stigma around mental health issues. That's a conversation that we intend to continue this morning. The history of substance abuse disorders in the U.S. is one marked by, again, stigma, criminalization, and a lack of recognition that these issues are health conditions requiring evidence-based treatment in the same way we treat diabetes or hypertension. Without necessary mental health treatment and supports, millions of Americans face severe illnesses, addiction, incarceration, and death. Due to longstanding social and economic inequities, historically marginalized groups in the United States face particularly bleak outcomes. We must finally take on these issues in a serious, holistic manner. It will take all of us working together to address this often invisible suffering across many communities. Fortunately, the White House also recognizes the need for urgent collective action. I'm grateful and very pleased last night during his State of the Union address that President Biden announced his strategy for addressing the nation's mental health challenge. Together, we can build on the foundation we laid in the American Rescue Plan to ensure that everyone who needs mental health care is able to access it. Today's hearing is an important step in tackling the problem. Testimony today will help to inform the legislative action that the committee will take this year to address some of the long-standing problems in a way that we deliver and access mental health services across our nation. With that, let me recognize the ranking member, Mr. Brady, for the purpose of an opening statement.
Thank you, Mr. Chairman, for holding this important hearing. Thank you to our witnesses, and I too am glad to see the committee back together in 1100 and working on important issues. So with substance abuse use on the rise among other risk factors, including social isolation, American families are facing a real mental health crisis. During today's hearing, we'll hear about those real-life challenges so many Americans across the country are struggling with. These problems can impact anyone, seniors, veterans suffering from post-combat mental health challenges, and our children. Everyone is touched by these issues. To help these patients and their families, we need to recognize and stop policies that worsen despair and disconnection and get back to working together to strengthen America's communities. I worry the Biden administration's mishandling of the pandemic, including tests, treatments, and therapies, and prolonged shutdowns and social isolation, have only exacerbated the hardships facing American families. Half of all seniors reported that during the pandemic, they were isolated and spending less time doing the things they enjoy. Without the routine and social environment provided by school and sports, suicide attempts by teenage girls increased by 50%. 2 out of 3 patients and families with substance use disorder reported the pandemic had a negative impact on their recovery, citing an increase in stress and isolation. Critically today, America is in the midst of a drug epidemic fueled by fentanyl, a deadly substance, which is now the leading cause of death for Americans age 18 to 45, the leading cause of death. Overdose causes by fentanyl have doubled in 30 states in the last 2 years, including my state of Texas. These are real families and real communities that are being devastated. We must do more together to reduce the prevalence of fentanyl, which must include solutions at the border. We see this firsthand in Texas, where the open border policies of the administration allowed fentanyl to flow across our southern border and into our communities. Just last year, the U.S. Customs and Border Protection seized enough fentanyl to kill every American nearly 7 times over. And in the fallout of President Biden's open border policies, the administration diverted $850 million meant to support the nation's COVID-19 testing capabilities, instead using the funds to house individuals who crossed into America illegally. Last month, I had the opportunity to talk to Sheriff Montgomery County in Texas, Rand Henderson, who told me about the challenges local law enforcement is facing with the rise of fentanyl. He told me more and more that their drug seizures, including all kinds of fentanyl-laced drugs, including marijuana, not able to stop or even slow the amount of this dangerous drug entering the country. American families and communities will continue to suffer. We can work together to fight the rise of opioid use and other forms of substance abuse that occurred during the pandemic. This is an important issue for Republicans, certainly. As majorities in the House and Senate, we led a historic investment in combating the opioid crisis and reducing substance use disorder throughout America by enacting the SUPPORT Act. The bill put in place many common sense measures to reduce the unnecessary prescription of opioids and also help those who become addicted. But I'm afraid we've taken our eye off the ball. Because of the pandemic, the sluggish restart of the economy, the influx of illegal drugs resulting from open borders policies, it's clear America has lost momentum. The patients and communities that started to see hope as Congress was passing support now feel neglected. It's critical we renew our commitment to every American who's impacted by directly or indirectly by substance use disorder or mental health challenges. We can build on and improve the SUPPORT Act and assess new challenges in combating these issues. The committee can also work together to make telehealth access permanent. First year of the pandemic, the national weekly average of telehealth users jumped from 13,000 to 1.7 million. Telehealth was critical for delivering mental and behavioral health services. By increasing access during that crucial time, having the option to use telehealth has saved countless lives of seniors and those facing dire mental health issues. At the end of 2020, Congress was able to work together on a bipartisan basis to permanently extend many of the telehealth flexibilities for mental and behavioral health services. But we need to build on this more and permanently extend further telehealth flexibilities that can help seniors. And finally, this committee should work together to get more Americans off the sidelines and ensure our economic recovery. We heard from President Biden last night that's something he'd like to work on, but the first step is to stop making things worse. I continue to urge the President to abandon his plans for crippling tax hikes on Main Street, lavish giveaways to special interests, and more runaway spending. I'll close here. On the heels of a raging pandemic and a terrible recession, we know the mental health crisis is real. I believe we have the tools to fight it, and I believe that together, taking a bipartisan approach, looking at the leadership of Chairman Neal, of Democrats and Republicans on this committee, I'm convinced we can do that. So let's work together, and with that, I yield the balance of my time.
Thank you, Mr. Brady. And without objection, all members' opening statements will be made part of the official record. I want to thank our witnesses for taking the time to appear before us today, and I'm pleased that we are able to welcome 5 very impressive guests to discuss this important issue. First, I have the honor of welcoming Dr. Jonathan Metzl, Professor of Sociology and Psychiatry and Director of the Department of Medicine, Health, and Society at Vanderbilt University. Next, we have Dr. Edwin C. Chapman, a private practice physician specializing in addiction medicine. Regina LaBelle, the Director of the Addiction and Public Policy Initiative at the O'Neill Institute. Next, we have Dr. Marielle Reyataza, Executive Director of the National Asian Pacific American Families Against Substance Abuse Organization. Finally, we have Jessica Halsey, founder of the Addiction Policy Forum. Each of your statements will be made part of the record in their entirety. I would ask that you summarize your testimony in 5 minutes or less, and to help you with that time, please keep an eye on the clock that should be pinned to your screen. I will notify you when your time has expired. Dr. Metzl, please proceed.
Well, thank you very much, Chairman Neal, Ranking Member Brady, and the members of the committee. It's really an honor to speak here today, and I'm so pleased that we're having a testimony about this really important topic. Hopefully, the next time we do this, I can come in person and we open the room to everybody, and then I won't have to be speaking from my kitchen. But I think hopefully my message will get through nonetheless. I'm, as you just heard, somebody who is on one hand a trained psychiatrist, and over the course of my career, I've seen really up close the devastating effects of the topics that we're talking about today: depression, suicide, addiction. And really, I agree with everything that we've just heard, that these know no boundaries. They cut across party, ideology, and geographic locale. And at the same time, I'm also a social scientist. And so at Vanderbilt, I direct a department, Medicine, Health, and Society, that studies how social structures, infrastructure, things like that contribute to and also give resilience to what we're hearing are really, I think, rightly described as a national emergency about the need to address mental illness issues broadly, and also really the urgent issues of addiction and suicide. Now, certainly, as I'll say in a minute here, I think we need more and better treatment, more specific treatment. I think we need to reach out to people in communities in ways that they understand and respond to address what I think the president rightly called last night a national emergency. But I would also say in my written testimony that as I sat down to write some of my thoughts, I just started thinking, think about everything we've all been through over the past 3 years. I mean, who would have imagined that even breathing somebody else's air, or walking into a room, or thinking about whether or not somebody is carrying a virus or something like that, we've all been through this kind of national trauma, and we've dealt with it in ways that I think highlight historical polarizations. But I think it's important to note that mental illness is an extreme point of a continuum, but really I think if nothing else, this pandemic has taught us that we are all on a spectrum of vulnerability. And in a way, one of the things I argue toward the end of my statement, my written statement, is that I don't think we've really had a national conversation just about what mental health means after what we've all been through for the past 3 years. And so one of the things that I suggest toward the end is that we have a sort of national referendum, and it seems kind of pie in the sky, but a non-polarizing national referendum on just what mental health means in this new world that we're all living in, and how do we come together? Because I will say, and I completely agree with what we've just heard, that there are so many groups voicing despair right now, that it's my hope that we can build mental health as a resource. Now, I will also say that as a psychiatrist, I can tell you that there are many of my colleagues on this panel will be saying many important things that we can do at the moment. We've heard about the crisis of isolation that's happening, and I know that the president talked about technology last night, but I agree that it's time to think about how can we reach out to people, how can we create networks, how can we contact them within and kind of break the cycles of isolation. I think more insurance, more exchange coverage, substance use disorder treatment, and I agree completely with the need for telehealth right now. I think it's an opportunity for us to use technology for the good. But my written testimony and what I'm saying today is also that of a sociologist. I link mental health with and individual pathologies with larger structures and systems. And so the other part of my written testimony, the other point I want to make today, is that the pandemic highlighted and exacerbated structural inequities that underlie mental illness. I think Chairman Neal highlighted this very well in the opening statement. And I will say that it was also a call to action to fix the underlying structural inequities that we have. And conversely, I think there's a lot of evidence from history that societies that bond together and build what's called social capital or social cohesion end up breaking cycles of despair in very important ways. And so I won't go into it because a lot of this is in my written testimony, except to say that I think we have an opportunity to build social structures that emphasize the importance of communal infrastructure for mental and biological well-being. I realize I'm out of time, but I thank you very much, and I look forward to having this discussion through the day.
Thank you, Dr. Metzel. Dr. Chapman, would you please proceed?
Thank you, Chairman Neal and Ranking Member Brady and committee. Thank you for allowing me to participate in today's hearing. Dr. Edwin C. Chapman. The past 42 years, I've been practicing internal medicine just 2 miles from our nation's capital. In 2000, I began treating patients suffering from opioid use disorder as a medical director, one of the 3 methadone clinics in the District of Columbia. In 2005, I began using buprenorphine, another FDA-approved medication, which is a partial agonist, treating patients in my personal office. And over the past 17 years, I've treated a total of 1,100 patients and currently take care of 225 patients. What we found was that these patients have a plethora of problems, including the fact that 10% of my patients have spent at least 10 years or more in jail. 50% initially tested positive for hepatitis C, 10 to 12% test positive for HIV. So historically, we know that many epidemic outbreaks, both HIV/AIDS and hepatitis C, are related to untreated substance abuse. As we've seen in Scott County, Indiana, Lawrence, Massachusetts, West Virginia, and of course, the District of Columbia. So I was appointed in 2019 to a year-long team studying the integration of opioid use disorder treatment and infectious diseases under the guidance of the National Academies of Science. And we identified 9 major barriers, including stigma, that's been talked about extensively. But we also noted prior authorization for medications like buprenorphine are consistently noted as the #1 barrier by the American Medical Association, the American Society of Addiction Medicine, as well as NASAM. So in District of Columbia, for example, one of the 3 Medicaid MCOs currently has a 6-page prior authorization form for buprenorphine doses above 24 milligrams, although the District of Columbia ranks #2 in per capita overdoses. And that means that it's far easier for a person to get fentanyl outside of my office than a prescription for me. Secondly, there's a lack of a national standard of care for care coordination, and multiple plans have different ways of doing this, including Medicare and Medicaid. So we often do not allow for multiple same-day services, nor services outside of a professional office setting, or reimbursement for critical services provided by social workers and peer support counselors. The 2020 Federal Register pointed out that it costs $42,000 to treat untreated a patient. Costs the system $42,000. It only costs $7,500 to treat a patient, which means that there's a $34,500 savings per patient if treated. So tertiary costs plus additional, what I call wrong pocket costs per individual, could easily exceed $100,000 per patient per year, even if that person happens to be single and homeless. So we envision a more simplified payment system, a bundled payment system, appropriately scaled, encapsulating all the savings described herein, and a prescriptive formula that will not only save lives and taxpayer money, but also attract more provider participation. And we actually have that formula through the American Society of Addiction Medicine and the American Medical Association patient-centered opioid addiction treatment, or PCOT model. But this model, which was put together in 2018, was never adopted by any state or any insurance plan. So we invite you to further explore this option as a fast-track national innovation in building an incentivized network of competent providers. And I'll stop there.
Thank you very much, Dr. Chapman. Ms. LaBelle, would you please proceed?
Thank you. Good morning, Chairman Neal, Ranking Member Brady, and members of the committee. Thank you for the opportunity to speak to you this morning. In 2021, I served as the acting director of the Office of National Drug Control Policy. There, I oversaw the development of the Biden administration's initial drug policy priorities. Currently, I direct the Addiction and Public Policy Initiative at Georgetown Law Center, where we use the law and policy to promote access to quality addiction treatment, harm reduction, and recovery support services. In addition, I direct Georgetown's Master of Science in Addiction Policy program, where we train future addiction policy professionals. So I'm here today to discuss this critical issue affecting our country. And as we all know, the Centers for Disease Control and Prevention reported that from April 2020 to April 2021, over 100,000 people died of a drug overdose in our country. This situation calls for heightened attention by policymakers and the public to provide both more resources, but also acknowledge the need for tailored responses to the challenge of addiction. In 2021, the Biden-Harris administration published its first-year drug policy priorities, and as you heard last night from the president, this is a comprehensive strategy based on scientific evidence that spans the entire continuum of care. These priorities offer a pathway to action that can guide a more comprehensive response to today's urgent issues. Now, the health of people with substance use disorders and the communities in which they live is often determined by social factors, and effective policy requires tackling not only proximate factors, but also comprehensive solutions to provide greater stability and community connection, which is especially important in this time of COVID-19. So I want to highlight 3 areas for action. First, protecting children from harm. We know that childhood trauma is linked to the later development of substance use disorder, and legislative initiatives like the child tax credit and expanding the availability of family-centered approaches to treatment can provide services, keep families intact, and reduce adverse childhood experiences. Also, stigma toward people with substance use disorder not only increases the harms associated with that condition, it can also prevent people from receiving needed services. So to prevent risky substance use and limit their harmful impact, we have to move aggressively to limit the stigmatization of people with addiction. Strengthening housing security. Now, stable housing can improve health outcomes for people with addiction. So there are a couple pieces of legislation that's being considered that might help in this area. The first is the Affordable Housing Resident Services Act of 2022. This would create grants to provide services for people with substance use disorder in affordable housing. And then secondly, the Neighborhood Homes Investment Act. This is a bipartisan legislation that would incentivize development of affordable housing by creating a federal tax credit to build or develop homes in distressed areas. Now, another critical area for intervention is a greater focus on addressing substance use and mental health conditions in corrections. So according to the Bureau of Justice Statistics, in 2019, suicide was a leading cause of death in jail. Jail deaths are increasing year after year. From 2009 to 2019, the rate of jail deaths due to drug or alcohol intoxication more than quadrupled. So research we conducted at Georgetown found that withdrawal-related deaths are preventable if correctional settings provide withdrawal management upon intake, as well as access to longer-term treatment. The Bureau of Justice Assistance recently used this research to develop a set of recommendations for preventing harms from unsupervised withdrawal in jails. Lack of treatment during incarceration and a lack of community-based care place individuals at great risk. That's why the Medicaid Reentry Act would ease reentry by enabling patients to reestablish Medicaid benefits before they reenter communities. So in closing, too often we think about these issues as being resigned to their intractability. But these challenges don't have easy solutions. But I really believe that there are concrete policy steps, often with bipartisan support, that can make a big difference and strengthen our communities. Thank you for your time. I look forward to your questions.
Thank you, Ms. LaBelle. And now we will hear from Dr. Rayataza. Please proceed.
Chair Neal, Ranking Member Brady, and members of the Ways and Means Committee. It is an honor to testify today. I'm Dr. Marielle Rayataza, the Executive Director of the National Asian Pacific American Families Against Substance Abuse, and we've served Asian American, Native Hawaiian, and Pacific Islander communities for over 30 years. I have 14 years of experience on working closely with communities, and I currently serve on the SAMHSA Steering Committee on Harm Reduction. I'm also here today as an Asian American, and more specifically, a Filipino American immigrant. I have particular concern over the health and wellness of API communities. First, it's worth noting that broadly, the term API represents people from approximately 50 ethnic groups and over 100 spoken languages. This has resulted in misunderstandings about APIs and thus a lack of culturally and linguistically appropriate mental and behavioral health services. Unfortunately, there's already an ongoing stigma within our communities when it comes to seeking care. This stigma can be so strong that there's delay in seeking care, or worse, we don't seek care at all. Sometimes individuals must also seek services in private, and that happens even when telehealth is available, which can be challenging since we often live in multi-generational households. Additionally, telehealth is not always feasible, especially if language access and technology are already barriers. Additionally, navigating overly complex and confusing systems of insurance and providers is already difficult for most, but this can be especially hard for AAPIs. For instance, an estimated 34% have limited English proficiency, and finding language-appropriate care continues to be difficult. With approximately 2/3 of AAPIs being born outside of the U.S., understanding cultural nuances is critical to serving us. Thus, it's not surprising that SAMHSA has reported that AAPIs demonstrate the lowest help-seeking rate of any racial or ethnic group, creating the illusion that we don't need them. Many have called for the COVID-19 pandemic to be redefined as a syndemic, acknowledging the disproportionate impact on communities. For instance, the community-led team of researchers found that Native Hawaiians and Pacific Islanders experienced the highest per capita death rate in the U.S., which have been attributed to health and socioeconomic inequities that existed prior to COVID-19. Notably, many Asian Americans, despite living in cities that boast a robust Asian American community, have received imprecise or no information in their native languages. Additionally, while Filipinos and Filipino Americans make up only 4% of registered nurses in the US, they make up nearly 1/3 of all COVID-related deaths among RNs. The pandemic has also resulted in a significant rise of anti-Asian hate crimes. Between March and September 2021, 10,370 hate incidents against AAPIs were reported, with AAPI women and girls persisting as prime targets. 1 in 5 Asian Americans experiencing racism have been found to display psychological and emotional harm caused by racism, showing heightened symptoms of depression, anxiety, stress, and post-traumatic stress disorder. Without appropriate and accessible care, substance use disorder among AAPIs is also believed to be on the rise. Some localities saw a 196.1% increase of accidental overdose-related deaths among Asians during the first 5 months of the pandemic. Lastly, suicide is also reported as the leading cause of death among API youth and young adults aged 15 through 24, despite it being the 10th leading cause of death in the US. This is the cause of death for 33% of our young adults. Knowing the reluctance that we already demonstrate in seeking care, combined with a lack of disaggregated data among APIs, I have much reason to believe that cases go underreported and require much more investigation to be well understood. One way in which this can be improved is by increasing capacity for community-led research. Frankly, we are underrepresented in these studies, and this is further complicated by the fact that there's a large percent of us, again, that are immigrants and sometimes undocumented. Additionally, I urge the committee to build capacity for improved culturally responsive services and language access. Second, I urge the committee to grow capacity for data disaggregation in collection and reporting. Because APIs also represent diverse socioeconomic statuses, I recommend that data also be stratified for additional demographic factors. Third, I urge the committee to proceed with the adoption of harm reduction principles and practices. This can look like a number of things, such as peer-driven support networks, community support through education, needle exchange programs, safe smoking kits, pill take-back programs, medication-assisted treatment, and safe consumption services. Harm reduction is comprehensive, wellness-centered, reduces disease transmission, and saves lives. Harm reduction is also science-based and community-vetted. With mental and behavioral health providers already in demand greater than we can fill the need, I worry about the long-term impact of this endemic on mental health. I acknowledge the challenge in speaking about a group as large and diverse as ours, but also know that we need help. I thank the committee for inviting me to testify.
Thank you, Dr. Rayataza. Ms. Halsey, would you please proceed?
Thank you, Chairman Neal, Ranking Member Brady, and members of the committee for having me here today. My name is Jessica Halsey, founder of the Addiction Policy Forum, a nonprofit working in states and communities across the country to end the stigma around addiction, to help patients and families in crisis, and to translate the science. Over the last 2 years, as our country has grappled with the pandemic, addiction has worsened at historic rates. The isolation, stress, and disruptions in the pandemic were in too many cases catastrophic for our patient group. We conducted at APF a survey and interviews during COVID with our network of patients, and one of our patients shared, "I would say living in recovery through this time and not being able to be active in meetings has been disappointing when they keep liquor stores and weed shops open. The society is so twisted." We're also releasing later this month a patient journey map, which helps us to understand the treatment and recovery process through direct input from our patients. And the project has so many findings, but just one to share with the committee is that one of the most difficult points in the entire process, highlighted by our patients themselves, is how hard it is to find help, how difficult it is. One of our patients shared, and this is a direct quote, "So in my experience, I was not able to get help when I needed it, or when I asked for it, or when I begged for it." And to make matters worse, the introduction of fentanyl into our drug supply has significantly increased mortality rates. Fentanyl is 100 times more potent than morphine, 50 times more potent than heroin, and the mass production of fake pills marketed as legitimate prescription pills has devastated our communities. The result, 104,000 drug overdose deaths in 1 year, and that's 285 deaths a day. Like a plane crash every single day in America, like losing a high school class of seniors in 1 day, every day in this country. I know firsthand this devastation as I lost both my parents to opioid use disorder, but my story is just one of millions repeated daily across our nation. To put a different lens on 104,000 deaths in just 1 year, I'd like to take a moment to share letters from our families that are a part of Addiction Policy Forum's Stop Overdose campaign. We have hundreds of these letters, and I only have 5 minutes, so I'm going to just introduce you to a few of our families. Christina lost her son, Jonathan, to a fentanyl overdose. She writes, "He was my oldest son. He made me a mother. People to know that this is a disease and not a choice." Jim's son, Scott, this is Jim and his beautiful son, Scott. He struggled with mental health and opioid use disorder. After 3 years in recovery, Scott relapsed, which led to his suicide just 2 days before his 21st birthday. He left a letter for his family, which read, "I have not found one person who can help me. I love you, Mom, Dad, and Ashley so much, and there's nothing you could have done better. I just can't stand being in my own mind. It's torture and it hurts, and I've tried for years to get help, but nothing works." And Denise, one of our moms, Denise, she lost both her beautiful sons, Matthew and Dylan. This is Matthew and Dylan, to an opioid overdose. She shares, "My boys had a bright future ahead of them, but because of their illness and lack of adequate treatment and medical coverage, Their lives were cut tragically short. Had they suffered from diabetes or cancer, they would have been provided the medical care and attention necessary to live a full life. What is so frustrating to me is that we have most of the proven tools we need to address the crisis, yet we do not systematically implement these interventions for those in need. For example, medications to treat opioid use disorder, or MAT, reduce opioid use, overdose deaths, criminal activity, and infectious disease transmission. Research shows that individuals treated with buprenorphine or methadone after a non-fatal overdose had a 40 to 60% reduction in mortality. Yet less than 50% of our privately funded addiction treatment programs offer MAT, and only 30% of the patients there will actually receive it. Can you imagine if less than half of oncology centers provided chemotherapy, and in that half, only 1 in 3 patients received the medications that we needed? If we feel shock or horror even at the thought of this, then why is it the case for addiction treatment? Our recommendations for the committee to consider are expanding critical services that are proven by science, like widespread community-based naloxone distribution, contingency management therapy for stimulant use disorder. We have a polysubstance use disorder, not a single drug issue in this country, and we need to have more solutions for stimulants treatment, syringe service programs, and medications for addiction treatment. Number 2, build the addiction workforce by addressing lack of coverage for many providers in the field, low reimbursement rates, and create incentives for this pipeline of workers that we need. And then finally, go upstream. Addiction is a pediatric brain disorder, and evidence-based strategies are available yet underutilized to prevent children and young adults from developing an SUD in the first place. Thank you so much for your focus on this important issue and for having me today.
Thank you, Ms. Halsey. Without objection, each member will be recognized for 5 minutes to question our witnesses. In this hybrid setting, we will dispense with the Gibbons rule and will go in the order of seniority, switching between majority and minority members. Before questioning our witnesses, without objection, I would like to enter into the record a statement of a musician and rapper, Sir Robert Bryson Hall II, known professionally as Logic. In 2017, he released the song 1-800-273-8255, which is the current phone number of the National Suicide Prevention Lifeline. His song drew much attention to the suicide hotline and helped many that needed help. The National Suicide Help Hotline number is 1-800-273-8255, and anyone can call any time of day or night to be connected with help. This past December, the Biden administration announced $282 million worth of investment to strengthen and expand the Lifeline, and in July, will change the 10-digit number to a 3-digit code, 988, that will accept calls, texts, and chats. I encourage every member of the committee to work to publicize this current number and the new one when it goes online. And with that, let me turn to our questions for our witnesses. Let me begin by recognizing again Dr. Chapman. I want to thank you for your testimony, particularly for sharing the struggles of your patients and seeking the care that they need. DC is lucky to have you as a provider. I was proud of our bipartisan work in this committee through the Support Act in 2018, particularly in my bill that added opiate treatment programs as Medicare providers. That was a big deal. While that step was important, it is clear that this was just a first step in ensuring Medicare beneficiaries have access to a full continuum of services for all types of substance use disorders. Dr. Chapman, can you talk about the challenges that Americans face in getting necessary substance abuse disorder care, and whether, as a result of gaps in health care coverage and other social and structural factors, intervene?
Thank you, Mr. Chairman, for this very probing and insightful question. We have tremendous gaps in care, first in insurance. In the district, however, 98% of our patients are covered. So I was on a panel at the Brookings Institute about 3 years ago, and Alice Rivlin asked a very probing question. Is it money or is it structure? And I think the consensus was that it's both. The fact that we have these structural barriers to care. And I mentioned prior authorizations. but there are many other barriers. For instance, if a patient comes to see me in my office, we set up telemedicine six years ago, anticipating the need for psychiatric services, social workers, peer support services. But most insurance companies do not pay for multiple services on the same day. So under the old system, if a patient came in and they saw a for primary care or wanted to see a psychiatrist, one of us would not get paid. But the idea of value-based treatment means that when we're challenged with patients who have limited resources, we want to do everything we can while we have that patient in front of us. So when we set my office up, if a patient came in needing to see a social worker and didn't have a telephone, we could put them in an examination room and connect them with a social worker. Call that reverse telehealth. So we've been doing this for 6 years very successfully, but there's no payment structure to support that. So we're really looking for a consistent payment structure from Medicare, Medicaid, across the board that will support these very necessary services. There are other issues like transportation, housing, of course, is a major issue. Anywhere from 25 to 50% of our patients in the District of Columbia are homeless, depending on how you define homelessness. They may not be homeless on the street, but they may be couch surfing or living with a friend or a family member. But again, that puts those patients in dangerous situations where they're not able to always control their environment. So housing, as far as I'm concerned, is medicine. Without housing, we're actually creating a revolving door, treating patients when they come in the office or go in the hospital, but really discharging them back to the same dangerous environment.
Thank you, Dr. Chapman. I want to reference a follow-up question. In my congressional district, the Hampden County Sheriff's Office runs a number of programs that navigate the intersection of mental health, substance use, and the justice system. The All-Inclusive Services and Supports Program provides a pretty significant conduit to employment, stable housing opportunities with intensive wraparound services, education, and social support for individuals reentering the community. The former sheriff and the current sheriff of Hampden County, both very good public servants and very fine people, they've pointed out to me in conversation that at different intervals, up to 90% of the inmates either have an alcohol, drug, or mental health issue. Would you talk a bit about why programs are needed to address some of these issues inside of these institutions?
Absolutely. Heretofore, less than 5% of jails and prisons across the country use medication-assisted treatment. As a matter of fact, they would take patients off of buprenorphine or methadone if they were incarcerated, which means if you could imagine a diabetic being admitted to are being incarcerated and taken off their insulin. It's unheard of. But again, it boils down to stigma. Without education and without understanding what these medications are used for, our criminal justice system considers this just replacing one drug with another. So we have to start with professional education, both in the medical field as well as in the criminal justice field, so that they really understand what these medications do. As I alluded to in our National Academy of Science report, that untreated, the worst place to put a patient who's using drugs in jail is in jail, because that's going to be the highest rate of transmission of infectious diseases. In Maryland, a number of years ago, they they actually prohibited buprenorphine because they said that it was being smuggled in the leaves of books and under stamps and so forth, which means that you create a black market within the jail. The easiest way to stop that black market is to provide medication assisted in jail and then have those patients or clients transition from jail back into the community to a provider without interruption, just like any other medication. We can stop this black market and these gaps that we're currently having by simply providing those services and making a warm handoff in advance. So patients many of them need insurance that can be accessed 30 days before they're being discharged. And I think when you talk to Regina LaBelle and her work at Georgetown University, that you'll see that they have these policies really nailed down to the nth degree in terms of what needs to be done. All we need to do is follow the policies.
Dr. Metzel, thank you for testifying today, and the work that you're doing to explore ways to heal the American people in this time of heightened stress is certainly invaluable, and we want to continue that conversation. In May of 2020, the committee held a hearing that explored the disproportionate effects of COVID-19 pandemic on people of color. It was clear that the pandemic was exposing long-standing inequities in our healthcare and economic systems. In your testimony, you highlight how this inequitable system affects and exacerbates risk factors for depression, addiction, and suicide. What do you think Congress might do to more structurally address these issues?
Well, thank you so much. Really wonderful question. I would say, first of all, that it's not reinventing the wheel. There's a great deal of sociological medical literature, some of which I cite in my written report, and then that's just the tip of the iceberg, that talks about how in moments when societies are challenged by wars, famines, pandemics, in ways that highlight structural inequities, that if you kind of create what sociologists call social capital or social cohesion, if you actually move not to talk about people's identities, but to actually say, look, here are the fault lines that are being exposed by this moment of crisis. And what we're going to do is we're going to have a national effort to actually fix these fault lines to help people who are the most vulnerable in our society, but also protect society. Now, I give just a few examples of something like this. I mean, it's pretty remarkable. For example, one of the pieces I cite in my written testimony talks about just the effect of providing healthcare networks in low-income communities. People, of course, are able to access all kinds of care, mental health care and physical care, but the kind of unintended effects of broadening healthcare networks, as one example, have all of these other kind of people kind of feel like they're part of a network. And so you'll see things like optimism go up, participation, civic participation, participation in community rebuilding efforts, parks, and all those kinds of things. And so point number one that I make in my report is that I think we really need to think about infrastructure as not just like, let's fix some bridges or roads that are broken or something like that, but how can we fix infrastructure in a way that actually enhances people's sense of connectedness and the kind of feelings of mental health. And the other part, of course, is that those early stages of the pandemic that you mentioned really did highlight weak points of our society, that people lived in multi-generational homes. They had jobs where they couldn't possibly social distance. They had unequal access to information from the internet, for example. And so they didn't really know the most up-to-date safety information. And so in a way, these structural inequities were really brought into focus in those first moments of the pandemic. And we really had a choice as a society to either say, like, they are dying, those people who are less fortunate than us, or to say we are dying, our fellow citizens, our country, and really try to fix that. And so the language we use at Vanderbilt is called structural competency. Basically, what we advocate for is training health professionals both to understand individual systems, but also to see the weak points in structures, the upstream factors that might lead to downstream mental health issues and to inequities. And what we're hopefully doing is training legions of mental health practitioners and health practitioners practitioners who really are versed both in individual treatments, but also in these upstream factors about who do you need to partner with to help people pay their heating bill or give them internet access, and how can we reimagine medical clinics in that way?
Thank you. Dr. Rayataza, your testimony was superb again with the others this morning, and we acknowledge that the mental health crisis and its impact on Asian American, Native Hawaiian, and Pacific Islander communities is clear. We certainly have much work to do. Can you highlight ways that we can overcome some of these challenges to ensure that everyone has access to the care that is both structurally and culturally competent?
Thank you, Chair Neal, and I really appreciate the question. I agree with a lot of what has already been said by our colleagues today. A lot of the things that we have to really understand, as healthcare practitioners, whether we're in the mental behavioral space or other spaces of care, is that we don't really understand oftentimes how the systems work for different communities. And so I really, advocate for better understanding what is going on at the community level structurally. And I would argue also that identities also impact the way in which people interact with the health system, whether that's mental health and healthcare in general. There's a lot of gaps that everyone's already identified, whether it's lack of access, which we see time and time again. There's difficulty and challenge in navigating the system. And even when folks have access to insurance, often they're underinsured and access to these services are expensive and really challenging to navigate. What we often see is sometimes if someone has to go and see a provider, that means, they've got to take the day off. Does that mean that they get a sick day? Do they have to look for childcare? There's so many issues that are complicated by, just trying to get well. So I think that ultimately, the system is challenging. We've got to find ways to help people access it and navigate it. It's got to be affordable. It's got to be equitable. And a lot of that also involves learning how different cultures interact with the system and how to better address them appropriately, with also research as well and better understanding on those ends, with really prioritizing community-driven research as well.
Thank you, Dr. Rayataza. With that, let me now recognize the ranking member, Mr. Brady, for 5 minutes.
Thank you, Chairman. You mentioned that the National Suicide Lifeline is transitioning to a simple 988, which I think sounds terrific, but I didn't catch what the timetable is on that. When does that happen?
I think it's shortly. I think it's within the next couple of months or so. Yeah.
Okay, soon. So we ought to do our best to get that word out.
For sure.
So thank you for that. I know our law enforcement community deals with mental health issues every day, and I'm pleased to see our former colleague from the Ways and Means Committee and former Sheriff Dave Reichert from Washington State has joined us.
And might I say, a really nice guy.
And a terrific guy. So, although I think he enjoys sitting there than sitting here at the moment, Mr. Chairman. It's good to see you, Dave.
Some criminals who would argue with
So, there are criminals that would argue with us there. So, like the chairman said, thank you to all the witnesses. I want to, if I may, direct this question to Ms. Holsey. So thank you so much for being here today, sharing those heartbreaking stories in your testimony. Stories like Jonathan, Scott's, Matthew, and Dylan's are just powerful reminders of the devastating effects of mental health problems and substance use disorder have on communities across the country every day. And I would wager every member of this committee has a story as well, a friend, a colleague, a loved one who we've lost to these issues. I remember when we were first working on the Support Act in 2018, the dangers of fentanyl were really just coming into view for us in Congress. Now, just a few years later, fentanyl is the #1 killer of young adults in America. So think about that. If you have a child that's between 18 and 45, your biggest fear about losing them doesn't come from cancer, not from car accidents, not from crime. It comes from fentanyl. It is a shocking change how quickly this has occurred in our country. So, Ms. Holsey, since we passed the Support Act, How has fentanyl changed the substance abuse landscape? How do we catch up to these challenges?
I think fentanyl is driving overdose deaths and fatalities, not just in patients struggling with opioid use disorder, but stimulant use disorder, people using methamphetamines, cocaine, as well as prescription stimulants like Adderall, as well as sedative use disorder with so many counterfeit pills and counterfeit Xanax that's out there laced with fentanyl. We need to have ways to address this, to intervene sooner, to have more prevention, law enforcement strategies to disrupt fentanyl coming into our country and making its way into so many communities with devastating effects. One of our moms wrote in, her name is Angela, and she lost her beautiful daughter Emily to a fentanyl overdose, and she had 6 times what a therapeutic dose would be of fentanyl when she lost her daughter. With very little warning. So there's so much that we can do, but this takes a collaborative effort with both law enforcement and policymakers like yourselves, treatment providers, families, and making it easier to get the care that we need.
So Ms. Holstein, let me ask this. So you're in the trenches, you run a terrific program, you deal with this every day, you see the successes and you see where the shortcomings are. What is, for Congress, what is the most important thing we could do to help you succeed, both obviously in prevention, in providing services, in having that strength? What's the number one thing Congress can do to help you?
I think the number one thing that we need is to actually implement at scale all the things that we have learned and proven that work. It's very frustrating to be in this space and to, our families are at the epicenter of this, and there is so much loss that we're experiencing. And yet the science tells us all these things that we need. We have medications for opioid use disorder and alcohol use disorder. We would like some medications for stimulant use disorder, so we need more tools. But the tools we have decades of research that they work, and yet they are not implemented to scale. We have early intervention programs like ESPERT that works. We have programs for kids like me, impacted by parental substance use disorder. One in Essex County, Massachusetts, that's amazing. And yet we don't take them to scale. We don't implement systematically. We don't make all these resources and these findings from science available in all of our counties. And if we took steps to do that, I think that there would be a way for us to turn the tide around.
Great. Thank you so much, Ms. Holstein. And thank you again to all the witnesses. I yield back, Mr. Chairman.
Thank you, Mr. Brady. With that, let me recognize the gentleman from California, Mr. Thompson, to inquire.
Thank you, Mr. Chairman. Thank you for holding this important hearing, and thank you to all the witnesses for your fantastic presentation. I just want to go back and comment on one thing that was said earlier that I think was incorrect. President Biden has handled this pandemic quite well. First of all, he didn't deny it was real. He encouraged people to get vaccinations and to be careful. He provided critical funding for shots, for tests, and to get kids back in school. As a matter of fact, when he became president, 48% of our schools were open. Today, 98% of our schools are open. I think that's an important thing to mention. Also, as we talk about drug addiction and mental health, I think it's critically important to note that 25% of our world population is impacted by a mental health issue, and at least one mental health event in their life. And at the same time, around 70% of people with mental health issues do not have access to, nor do they receive treatment. We can talk about this all day, but unless we make some investment in neurological research, we are never going to get ahead of this curve. And I think it is important to point these things out. And I think it's a bipartisan issue where we should all be concerned with and figure out how we conduct that research and fund that research in order to deal with this problem that affects every one of us in every one of our families somehow or another. Dr. Chapman, I have a question for you. I've been working on telemedicine since my time in the state legislature in California in the 1990s. And I'm convinced that it's not only important, but it's critical that we make advances in this area. And I want to thank Ranking Member Brady for voicing his support for telehealth in his opening statement. This is something that we all need to work on to make sure that we make the advances necessary. But Dr. Chapman, you also mentioned telehealth, and you mentioned the key barrier for treatment to those struggling with addiction and mental health, and that's the stigma of both. Do you believe that by using telemedicine more generously that we can help deal with the stigma issues that surround addiction and mental health?
Thank you for that question, and absolutely. I'm not a psychiatrist, and in 2013, I went back to Howard University. I'm an internist. I went back to Howard University because I needed the support of the psychiatrists and social workers and psychologists. So when we designed this telehealth platform for an urban population, we looked at the profile of our patients. We looked at the homelessness statistics that I talked about. With homelessness, you know that patients don't have internet connections. If they have cell phones, those cell phones are very limited. So we had to design a process for a practitioner like myself that's in the city, not connected to a hospital. How am I going to get those services to a patient that walks in the office and their number one issue is that someone very close to them died, or they lost their housing last night. Those are the types of things that make providers not want to treat because they don't have access to those services. By bringing telehealth into my office, I'm now able to access simply by putting a patient in one of the exam rooms and connecting them to a social worker or connecting them to a psychiatrist, or if they're having legal problems with their parole officer, I can connect them to the peer navigator. That takes the burden off of me. That reverses provider burnout. And provider burnout is the number one reason why providers like myself will not treat these patients. Many providers have been certified and have an excellent number to provide buprenorphine, but because of these other support services that they're not able to institute easily, it scares them off, and they back off of treatment.
Thank you, Dr. Chapman. My time's expired. I yield back.
Thank you. Let me recognize the gentleman from Florida, Mr. Buchanan, to inquire.
Thank you, Mr. Chairman. I can't imagine anything more important than mental health, especially today. And I want to also thank all of our witnesses. Ms. Husky, I wanted to ask you, all of us, stories were so powerful. I have a nephew that's struggling. He was a semi-pro, very competitive hockey player, got addicted on drugs, and unfortunately, they've been battling, my sister, with him for 20 years. And it's an incredible struggle. It just seems once they get addicted, many of them, they go through that door. If you don't get to them early, and his is with prescription drugs, there's a good chance you lose most of them. I don't know what you find, but what more can we do up front in terms of prevention? it seems to me, whether it's the kids or anybody, if we can catch them early, it makes a big difference, because what I've seen over the years anyway, many of them, even if they figure out a way to manage it, it's brutal trying to manage it, the process. I mean, I know people have been successful and get across addiction on cocaine and alcohol or something, and they're going to rehab a month or a year every year, and they have to, or they'll lose everything. But what you touched on prevention. What's your thought? And I guess it's two questions. One is, once they go through the door, what's the chances of coming back, based on what you've seen with all your stories? But the bigger question for me is, how do we do more in terms of the prevention on the front end? Because otherwise, the cost and the pain and the suffering is brutal to families and communities.
Thank you for that. I'm so sorry your family has struggled with this as well. You know, going upstream, as we say, and both preventing addiction and intervening early is so critical in this. In no other illness would we wait for it to get worse before we would intervene. We would never wait for stage 4 cancer before we engage, patients in care. And the same is true for addiction. I think everyone can recover. Recovery is possible, and it is beautiful. And we have so many positive, inspiring stories of those that are in stable recovery and how they got there. We're even putting out a patient journey map later this month to detail that. You are right, though. The quicker we intervene when someone has developed a substance use disorder, the better the outcomes. And most addiction begins in adolescence or young adulthood. So making sure that we are intervening at the time of onset. Most of our treatment is set up for adults, yet onset is in adolescence. So that's something we really need to address. There are programs, we all know what EAPs are, employee assistance programs, but there are really successful student assistance programs in middle and high school.
And let me ask you just one more question, because we're running out of time. Yeah. As a member, nobody wants to get the call that I got last week, and we probably have all got the call. As a family, they found their son 3 tours in Afghanistan, committed suicide in the area that I represent, and it seems like it's 50% greater than the general population in terms of suicide deaths among our veterans. What's your thoughts and ideas about where we're at and what more we need to do? But I can tell you that one of the things I got left with, he says, we do a good job bringing the kids in, he's a Marine, into boot camp, but we don't do a very good job, his opinion, in terms of when they come out of the service, having also a boot camp. That was his term, on the way out. And his son has struggled for quite a while, and then he finally took his life last week.
Oh, I'm so sorry to hear that. I think that we do have treatments and interventions for those that have co-occurring disorders, meaning struggling with mental health and substance use disorders. And those services really need to be available to our veterans. We have interventions and programs that work. Judge Russell started a veterans treatment court, which is so successful and combines that wraparound services that we need for our veterans. But we don't apply those solutions at scale to all those that need it. I do think it should be a huge priority area that we focus our time and our resources to make sure that there's a safety net there.
Thank you, and I yield back, Mr. Chairman.
Thank the gentleman. Let me recognize the gentleman from Connecticut, Mr. Larson, to inquire.
Thank you, Mr. Chairman. Thank you for holding this important hearing. I want to commend President Biden last night as well for underscoring the need for us to come together around issues that I think everyone here in this committee agrees are nonpartisan and deserve our direct attention. Ms. LaBelle, in your testimony, you spoke about social determinants of health, which impacts substance use. In my district, the city of Hartford, a community which has deep poverty levels, accounts for over 25% of accidental overdoses. What policies do we need to pursue to address this addiction holistically?
Thank you, Congressman, and I'm very familiar. I'm from Connecticut. I'm very familiar with Hartford. I actually was there last year with the Office of National Drug Control Policy. And I think there are a couple things. First of all, there are good harm reduction programs that exist in Hartford. They get people who may not be receiving services elsewhere. They get vulnerable populations the help that they need. They get them naloxone. If they inject drugs, they get them syringes that can prevent them from having infectious disease. So that's one piece. I think the prevention programs, there are also examples of good prevention programs in that area that work to build communities of care that have wraparound services for families. So those are a couple things. And then lastly, I mentioned in my testimony, I'm a strong believer in the child tax credit to help families experiencing poverty, to lift children out of poverty, and also to address some of the adverse childhood experiences and trauma that often accompany poverty. So those are three areas that I believe strongly in that can help in that area.
Thank you for your answer and your clarity. With that, Mr. Chairman, I yield back.
I thank the gentleman. Let me recognize the gentleman from Nebraska, Mr. Smith, to inquire.
Thank you, Mr. Chairman. Certainly thank you to our panelists as well for this very timely discussion that I think is needed across our country. I appreciate the opportunity to continue this conversation that we began exactly a month ago with our last full committee hearing on how mental health care has been impacted by the pandemic. As I said then, the events of the last few years have made clear just how important the mental health component is to our healthcare system, especially when dealing with trauma and tragedy. Whether our constituents are impacted directly or indirectly, natural disasters like flooding or hurricanes, novel infectious disease outbreaks like COVID or Ebola, or even terrorism or barbaric wars like what is occurring in Ukraine can impact mental health and increase the risks of developing problems with substance abuse. We saw this risk clearly during the early days of the pandemic as alcohol sales shot up just as in-person support meetings were banned. Now, finally, we are seeing the COVID-related restrictions relaxed and people returning to normal social interactions, but long-lasting damage has been done, and nothing can bring back those who died of suicide or overdose while isolated from society, ostensibly for their own protection. Appropriate treatment for substance abuse or related behavioral health issues is more complicated than managing other conditions where a simple prescription can manage a health concern for months or even years. Instead, a major component is interaction with a therapist, counselor, support group, or other human being, but especially in rural areas, access to these resources is limited by virtue of distance and population density. Rural areas, such as my district, have consistently experienced shortages of all kinds of skilled healthcare providers, but especially those who work in mental and behavioral health. Addressing these long-term shortages requires innovation and creative approaches, often leveraging modern technology. One option to expand the number of mental and behavioral health care options in underserved communities, which I have been working on with Representative Chu, is the PEERS Act, an initiative to allow for peer support to be included in Medicare's integrated behavioral health coverage. These trained peer support specialists leverage their own experiences with mental health and substance abuse challenges, experiences of those already in our communities, to provide inexpensive and effective resources, helping address the provider shortfall. Another important opportunity to address access to care issues for mental health is to continue to grow telehealth capacity, as mentioned earlier. In rural areas, we lack a lot of these opportunities. There's widespread high-speed broadband demand that is not currently available, and that is impossible to appropriate the use of audio-only engagement. In the areas in my district where you can't even get a strong enough signal to make a call on a cell phone, you are also likely many miles away from the nearest mental health professional. Requiring people in these communities to have a high-resolution video connection in order to access telehealth care is just not a realistic option. For this reason, last year I introduced the Protecting Rural Telehealth Access Act, which, in addition to permanently removing barriers to rural telehealth originating in distant sites, would allow for audio-only provision of behavioral health services essential to those with mental health or substance abuse disorders. I hope these rural and underserved access concerns will be seriously considered and incorporated into a long-term telehealth package, which we need to chart a viable post-COVID course into the future. Ms. Hulsey, I'm wondering, what do you think are the most effective opportunities for us to use telehealth and new technologies to improve treatment and support for those with substance abuse disorders, especially in rural and underserved areas? And then also, do you think that audio-only options for behavioral health telehealth can be used to effectively expand access and provide support in rural and underserved areas without creating too much vulnerability for fraud and abuse?
Absolutely. I think expanding and making permanent some of the changes to telehealth that we saw during the pandemic will be helpful to increase access moving forward, including audio-only options for our physicians. It can be tricky to turn on that video component, and we need to make sure that we have better access and better connections with the right clinicians for all of our patients. We still struggle with the right reimbursement rates for services in the addiction treatment field, so we would love Congress to be able to work on that so we can keep and retain our clinicians that we have in the addiction field. And there are other solutions, and I think that these both telehealth and digital therapeutics do have application, particularly for rural communities where you might have more gaps in access to care or not enough variation of the types of care plans that some of our patients are looking for. Digital therapeutics enable us to use our smartphones to help with peer services, recovery support, connection to clinicians. A very important part of recovery is building a brand new social network and positive peer network, and digital therapeutics can be very helpful with that. So there's a lot of potential here. There are red tape pieces that need to be removed, and Congress, I think, can help us with those sort of next steps.
Very good. Thank you.
Thank the gentleman. Let me recognize the gentleman from New Jersey, Mr. Pasquale, to inquire.
Thanks, Mr. Chairman. I do appreciate the comments and the words of members on both sides of the aisle. There are things, obviously, that we can work on together, and we should, because that's part of our mental problems here. That there's a Democratic way and there's a Republican way. Yeah, when I was a mayor of one of the larger cities in New Jersey, I knew there was no Democratic way to pick up the garbage. And we look at those tangible things very differently than we look at problems that each and one of us have. Because no one's totally free from those problems. The last 2 years made us painfully aware. Our witnesses, excellent, each one of them. The testimony today removes all doubt that mental health and addiction is a crisis we face. Tens of millions of Americans are suffering from social isolation, fear of infection, job loss, burnout. The statistics are stark. Some of these things are easier to talk about than others. The reduction and use of fentanyl is easier to talk about than it is transgender. And what those folks have had to go through over the last few years from remarks from people in our own group, our own congressman. Not only hurtful, but very, very divisive. So during the pandemic, more than 1 in 10 adults reported using alcohol or drugs to cope with stress. Drug overdose deaths rose by 40% between 2019 and 2021, an increase of 29,000 people. Access to treatment is inadequate. Medicare is not subject to parity requirements. Often one must be hospitalized to even access treatment. Congresswoman Chu and I are finalizing legislation to modernize Medicare. It's an honor to work with her. Our fix requires mental health and substance use treatment across the continuum of services and settings. It's going to take us a long time to break away from stigma, a long time. This will improve access to essential mental health services. I would also like to point out that 25 to 50% of all people served by the mental health system have a lifetime history of brain injury, the loss of consciousness. Many of our soldiers. Those individuals often have longer and more severe histories of substance use and more behavioral health issues. We must support the individuals with substance use disorder to access and navigate treatment. I have been to too many wakes for friends and neighbors who are mental health system failures. I have attended too many funerals for young people who could not overcome their valiant struggles with addiction. Cannot fail to help tens of millions of Americans get access to care. If we do, more Americans will suffer and more Americans will die. Dr. Chapman, thank you for your great testimony, as each of the witnesses provided. Dr. Chapman, your testimony highlighted the gaps in substance use disorder treatment across various payers. Can you talk about some of the barriers that Medicare beneficiaries face, and what are the solutions that we may be able to apply to the Medicare program?
Thank you for your question. Absolutely. The support services that I mentioned before, including social workers, having peer support staff, is just critical. They save me so much time. And the system that we've set up allows me to introduce my patients to a social worker while they're in the office, and the social worker is at a remote site. Once those connections are made, then we're able to give 24/7 access. So that same patient can either call me if they have a problem, they can call the social worker, or they can call a peer support specialist that they've been introduced to. And this model has just been fantastic in terms of really closing some of those gaps. When we look at the savings, and I think one of the problems is, folks worry about how are we going to pay for these new services. But look at the savings. Look at the Federal Register and what it costs the system not to treat a patient. $42,000. Treatment, comprehensive treatment, spread across a population. I have a population of 225 patients. So you spread those costs across that population, and it may come to about $1.5 million. But every patient does not need that service every day. But when you spread it across that population, you end up saving money through the criminal justice system because they're not going to jail. You save money because they're not overdosing and going to the emergency room. And you're also able to re-engage patients, especially if they have children, so that their children are not going to foster care.
Thank you, Dr. Chapman. Thank you so much.
Thank you, Dr. Chapman.
Ms. Rondell, I yield back.
Let me recognize the gentleman from New York, Mr. Reed, to inquire.
Thank you, Mr. Chairman. And first, I wanted to recognize Ms. Hulsey. It's my understanding you have family members that you're associated with that are tuning in today. And just recognize Denise, Angela, Jim, who are watching and tuning into this hearing, obviously thinking about their loved ones that have been lost to addiction and opioids and fentanyl and all the issues we're talking about today. So our thoughts and prayers go with you each, Denise, Angela, and Jim, and we appreciate you using that horrific situation in such a positive way by participating today. Mr. Chairman, I will open my remarks by confronting the issue of stigma. As someone who surrendered to his higher power almost 5 years ago, dealing with the demons that we are talking about here today, I have to tell you, it is time for us to come out of the darkness. It is time for us to celebrate, as has been indicated by each one of these witnesses, recovery. The best decision I ever made in my life was that decision I made when I went to my knees and turned to my higher power in the program that I was associated with and wrestled that demon under control. And my life has improved so drastically in a positive way that I'm here to be a message for all those that are in the darkness still, all those that are facing addiction, all those that when they reach out for help and are denied, because I know exactly what that experience is, I will tell you, don't give up hope. Don't turn back to the demon. Don't give up. Because if you embrace recovery, if you have the strength to ask for help, I can assure you there are millions of us around this globe that are pulling for you, standing with you, and will do whatever it takes to get you out of that dark place and into the light of recovery. And with that being said, one of the things I experienced, and I think Alex Rivlin talked about it directly correct, it's a question of money and it's a question of structure. But I want to focus on the structure side of this conversation. Because what I have seen is that we have a silo effect of substance abuse counselors, and then we have mental health counselors. They're not reimbursed in a way that makes any sense to me under our federal health care system. That needs to change, in my humble opinion, and I hope every witness on this panel agrees with that. And then I've also seen that when we talk about a 12-step program where it calls for you to surrender to your higher power, that often our treatment providers will not talk about those spirituality issues, will not talk about the power of religion, because somehow that is something that should not be discussed in our public system. And I got to tell you, if you do not have a spiritual reawakening as part of recovery, it is very difficult to succeed. So I'm going to ask you, Ms. Huxley, how or is there a structural barrier to incorporating in documented successful treatment programs based on a 12-step spiritual-based type of recovery program that prevents you from treating or giving your patients, and Mr. Chapman, I'll ask you the same question, the best opportunity to get into recovery and succeed in life? Are there barriers that you face in your treatment model that we need to change to encourage that piece of the treatment protocol to be there for those that are suffering in addiction and mental health?
Absolutely, and congrats on your many years in recovery and for sharing your story. This is some of the pieces that we need to do more of, which tackles the stigma around addiction, to tell our stories. 12-step programs, all the different variations of support groups and mutual aid support groups that are out there are really sort of the foundation and a beautiful part of our recovery system in America. It's proven by science. We have the data. This works. It's helpful. In our research and our work with our network of patients in recovery from addiction, 64% of them rely on support groups for the long term. Like, this is what we need to stay well and keep healthy. And if you look at sort of the scientific components of it, you're attaching to your community, you are dealing with shame and self-stigma, you're creating positive peer connections, there's CBT built into the program, there's training and worksheets and knowledge that you need to manage your chronic health condition. It really is one of our most important resources. Some of the barriers can be misinformation and not understanding that you don't need to choose a brand of mutual support. There's so many different ones depending on your, a secular program or a religious program, some that are focused on certain substances. I think if we have more education for our providers and practitioners in the field, to let them know how important it is to be aware of what resources are in their community and making sure that when we have gaps that we build them.
And Ms. Huxley, I appreciate it, and I know my time has expired, and we could talk about this for hours, and I just want to thank the chairman for highlighting this, and know there are solutions here. especially with a program such as 12 Steps that has a 64% plus success rate. We should be embracing that and removing all barriers so that people get the help they need. With that, I yield back.
Thank the gentleman and appreciate the gentleman's courage in stepping forward in a public arena. With that, let me recognize the gentleman from Chicago, Mr. Davis, to inquire.
Thank you, Mr. Chairman, and let me thank you for this very important hearing. And Ms. Hustley, let me just thank you for your testimony and all of the witnesses, but also your interaction with my office. As chairman of the subcommittee with jurisdiction over child welfare, I'm deeply concerned that about 40% of youth come into foster care due to parental substance abuse, including about 20% of infants. This committee has bipartisanly invested in policies to strengthen these families so that children can grow up safely at home. Policies like federal reimbursement for inpatient family substance abuse treatment and outpatient services for parents to keep children from entering care, and the regional partnership grants like that received by Kentucky Start, as well as the various tax credits for children in moderate and low-income families. Ms. LaBelle, can you speak about how family-centered approaches to treatment that provide wraparound care for families can help limit adverse childhood experiences and children entering care?
Thank you, Congressman, for that important question. I think if we separate it into 3 stages, basically, of a child's life and taking into account the pregnant woman. So first of all, we need to make sure that pregnant women get the prenatal care they need, particularly if they have a substance use disorder. The stigma that's attached to women with substance use disorder often keeps them from getting very necessary prenatal care. So that's one piece. The second piece, that once that child is born, too often women postpartum women are no longer eligible for Medicaid, which often causes, again, women not to get the type of treatment that they may need if they have a substance use disorder. And then lastly, are those wraparound services, that family-centered care that takes into account that a child is not separate from the parents. And the parents and the child all need services. The parent may need treatment, but the parent may need other services, such as housing, such as parenting skills, again, to prevent foster care placements. The Family Prevention Act that passed a couple of years ago, the renewal of CAPTA that's happening right now, all those things can take into account that family reunification goal that we have. Thank you, Congressman.
Thank you very much. I've been told that drug addiction is a complex brain disease that is characterized as an uncontrollable desire to continue taking drugs with a tendency to increase over time, resulting in a physical and psychological dependence. With at-risk youth, there are many factors involved with drug addiction: early stresses, use of drugs by a family member, having peers or friends who use drugs, financial crisis, academic pressures, all kinds of things. What seems to work best, and what are the best practices with preventing and successfully treating youth using drugs?
Is that for me?
Yes.
Thanks. So I think, first of all, pediatricians for many people play a really important role for young people in identifying risky substance use. They may not be at the point where they have a substance use disorder, but that's why the early intervention by a pediatrician or a primary care doctor is really important. The second thing, I think, is the role of parents. I mean, many of us are parents, and we all think that kids don't listen to us. I certainly think about that with my son, but they do. And if you talk to kids about how risky early substance use is, and make sure they know that if they're using substances that they can talk to you so you can get them the kind of early intervention that they need. I think so the role of the parent, as well as certainly schools play an important role, but parents and communities. And then also the Substance Abuse and Mental Health Services Administration at HHS has some really good tools for parents on how to talk to their kids. It's called You Talk, They Listen. It's about, or opposite way, it's about basically talking to kids about alcohol use, marijuana use, two of which are the most commonly used substances by young people.
Thank you very much, and I yield back.
I thank the gentleman. Let me recognize the gentleman from Pennsylvania, Mr. Kelly, to inquire.
Thank you, Chairman. Great hearing. Mr. Reed and I are pretty good friends, and I know what he's gone through. So, Tommy, really good to put it out there so people know. I have a similar situation with a family member that started. This age of 14 really hit home with me because I've been going through this for 28 years, and I got to tell you, most people I think that have this problem wish they were the only person or the only family that had it, but it's not true. I'm just trying to get my eyes and my brain around this because the size and scope of this problem goes far beyond anything we can think. So all of you on the panel, thank you for what you do. I mean, it's like the myth of Sisyphus. You start pushing that rock up the hill, and as soon as you let go, it comes back down to the bottom. And I can tell you that only because I've been through so many starts and sat through graduations or whatever, or culminations, and felt so good coming out of that, only to find out that disease was waiting for this person out in the parking lot as soon as they left wherever it was that they were. But I was looking at this, and maybe you can all help me with this because I don't know where this ends. And this is my understanding that there's around 14,000 addiction rehab treatment centers in the U.S., serving a total of 3.7 million individuals. This industry, and you talk about a big business, this thing right now in 2020 was worth about $42 billion. That's billion with a B. And it's slated to grow to $53 billion by 2025, driven largely by private equity investments. That's not a criticism, it's just an understanding. This is a big business. In total, there's 11,200 pounds of fentanyl were seized at the border last year, and this is enough to kill every American 7 times over. And according to the Border Patrol in Texas alone, 87,652 pounds of narcotics, including 588 pounds of fentanyl, were seized from Mexican cartels. The street value of the seized drugs is $786 million. Why do I bring this up? I can remember President Trump talking very clearly about what he told his kids. Don't get started on alcohol or drugs because then you won't have to stop. And I look at this, and it's the old story. There's no secrets in our family. There's just a lot of things we don't talk about. The stigma of having this happen in your family is, well, does that then reflect on me that somehow I wasn't aware and I didn't do enough going in? I should have done something more. And we all have these wonderful pieces of legislation that we're telling people about, and we're throwing up that banner, say, this is what I co-sponsored, this is what I sponsored, and all this stuff. You know what? It hasn't made a damn difference. We are spending money like there's no tomorrow. And the rate of recidivism on this, and that's Ms. Halsey, that's one to ask you, at the cure rate. While we're always very optimistic that it's going to be okay, I just went through another entry program that's started 28 years ago with the same person. And I'm trying to figure, is there something out there where we don't know? The idea is don't get started, then you won't have to stop. Easy to say, hard to do. Anything that you can think of right now, I know we're aware of it, and you guys are dedicating your whole life to it. But we're only chipping away at an iceberg. I don't know how we change it. I wish we would have more briefings, more meetings and stuff. Chairman, you're doing a wonderful job on this, but you know what? We got to stop talking about it and find out where to direct the money. We're throwing money at a problem and just throwing it and throwing it and throwing it and thinking we're not getting a very good return on that. Maybe we're throwing it in the wrong places at the wrong time to the wrong folks. So, Ms. Halsey, if you can, and we're almost out of time on this, but I'm with you. I'm with you on this, and all of you do a wonderful job. Thanks for being with us today. And I think this is one thing. We're no longer Republicans or Democrats. We're just Americans facing the greatest threat to the generations that come after us that we have right now. So Ms. Halsey, and I know you don't have that much time to follow up on it, but we'll stay in touch with you. Any other ideas? I mean, I used to coach a lot of youth sports. I thought that was important. But you got to get these kids when they're young. And the destruction of our nuclear family is really one of the things that I really worry about. So anything, Ms. Halsey, that you can come up with that would be a positive, like, do this today now.
Well, a couple things. You're completely right about the when you don't start this or don't go down that road, that's easier. But most people with an addiction are struggling
Sorry, you
with
can go ahead.
alcohol use disorder. So delaying the age of onset, right? So the adolescent brain is so vulnerable. Prevention is really about pushing back when you start using anything. And we don't do a good job of telling teachers, coaches, parents that fact. We just put out an awareness campaign around this called Protect Your Brain, because there's this myth and misinformation. And then the other part of this is just addressing all the myths and misinformation that exists, from age of onset to waiting for rock bottom to this is like a acute issue, not a chronic condition that we need to manage for years. These are all things that we need to change, and Congress can play a really important role in helping us to get information out.
Well, listen, thank you all for being on with us today. Please don't walk away from this. We've got to defeat this, or we're gonna lose our whole country, the generation after generation.
Thank the
God bless
gentleman.
everybody.
Thank the gentleman. Let me recognize the gentlelady from California, Ms. Sanchez, to inquire.
Thank you, Mr. Chairman, for your leadership on this issue, and I'm glad to join the committee today as we take another step towards addressing our nation's mental health crisis. I want to thank all of the witnesses for your testimony today. It's been very enlightening. Over the last decade, our country has seen an increase in addiction and suicide. And for too long, the stigma associated with substance use disorders and other mental health needs has determined how we respond to these crises. Deeply rooted shame and barriers to care have made it difficult for many Americans to access the support that they need, and the consequences, quite frankly, have been deadly. In 2020 alone, nearly 150,000 lives were lost to overdose and suicide, and thousands more were impacted by the loss of a family member. We have, in my family, somebody who has struggled with addiction, so we know how heartbreaking that cycle can be. And my heart really goes across the nation for those that have lost a loved one, either due to overdose, COVID, or any of the stressors caused by the pandemic. As our witnesses shared, there's an urgent need to build a more equitable mental care system so that Americans from youngest to oldest get the care that they need where they need it. We have an opportunity to follow evidence-based strategies that will support all Americans across a continuum of care. And that's why I'm deeply troubled to learn that despite rising suicide rates, states like Florida and Texas are advancing policies that place LGBTQ youth at increased risk of suicide, with youths of color facing greater risk than that of their white counterparts. Specifically, Texas is encouraging state agency workers who are paid through taxpayer dollars to investigate parents who support their children for expressing who they are. Now, I'm a mom, and I firmly believe that no child who is part of a loving and affirming community should fear being taken away from them. Dr. Metzel, given your expertise on the structural, social, and environmental factors that impact mental health, could you speak a little bit more about the impacts of various forms of discrimination and racism on an individual's well-being?
Well, thank you so much for the question. And you're right that is basically exactly what my research focuses on. I'm not an addiction specialist. I actually just wrote a book on suicide in America, so I'm much more looking at the suicide component of this. And certainly there are several forms of discrimination that happen here. Certainly feeling like there is xenophobia or hatred directed toward somebody's own group, or even that their group is not being recognized by their own government or state or treaters or things like that certainly contributes to a sense of despair. This also goes hand in hand with a lot of the socioeconomic disparities that accompany stigma. So one of the sources that I cite in my report says that basically depression, of course, is 2 out of 10 adults during the pandemic, but it was 5 or 6 of 10 adults who have less than $5,000 of savings in their account. And so this despair goes hand in hand with socioeconomic factors that face members of disadvantaged groups as well. And so there's a real imperative to address economic inequity in a way that feels like people feel like they have a safety net. And then there are also just stress factors, known risk factors for issues like suicide. The last book that I wrote actually looked in depth at gun suicide. I know it's a very hot and contested topic. I am not coming at this as a pro or anti-gun person. I was born on a military base. I grew up in Missouri. I've been around guns my entire life. But I would also say that in moments of despair, having firearms around the home, giving firearms to people who might be at risk, in tense moments also increases particular negative outcomes. And so I do worry about what's happened with firearms in the context of the kinds of isolation, people particularly in the 18 to 21 age gap, also economic factors, economic stress, of course, lead to that despair. And so when you start to look at issues of disparity, what you start to see is that they link not just to societal attitudes toward particular groups, but they are what's called intersectional. They intersect with all of these other issues about socioeconomic class and factors like that I think are really important and a very vital part of this story.
Thank you. Dr. Rhea, sorry if I didn't pronounce that correctly. Like you, I grew up in a tight-knit community in Southern California. And unfortunately, that doesn't always mean that it's easier to openly talk about mental health issues. What do you know about the role that community-driven and culturally responsive mental and behavioral health services play in helping communities access the support that they need?
Thank you, Representative Sanchez, for the question. I think, ultimately, the role that we play as organizations such as ours, NAPA-FASA, we help to direct services and provide access to services that I think are otherwise inaccessible to communities such as ours. And, I'm also a native resident of California. I'm in Los Angeles. And so, we grew up with a large number of other minorities and communities. And so we see it time and time again that the models that work really, prioritize our own community members, our own community leaders, our own researchers to go into the communities and to be able to ask questions that we would otherwise not be able to talk about. There are also great models like the Promotores models that help us, with the Latinx community as far as, being able to engage with community members and helping them find direct services. And this goes along with healthcare and mental health and behavioral health services. This is similar to what we're seeing in the AA and HPI community is, people trust members of their own communities a lot more. And so, I really believe that one of the ways in which we can really strengthen how we address stigma in our communities, as well as all communities, is to really be able to talk to each other better. And that involves the community leaders and access to communities that would otherwise not be accessible.
Thank the gentlelady.
Thank you so much. I yield back.
Thank the gentlelady. Gentleman from Missouri, Mr. Smith, is recognized to inquire.
Thank you, Mr. Chairman. Substance use disorder is an issue plaguing our nation that Republicans take very seriously, and we have the record to prove it. In 2016, Republicans passed the Comprehensive Addiction and Recovery Act into law, making the first major federal legislation devoted to combating substance use disorder in 40 years. But we didn't stop there. In 2018, with President Trump's leadership, we passed the Support for Patients and Communities Act into law. This legislation included several important provisions, including one I personally worked on and wrote that was designed to monitor the use of opioids during surgery to reduce the chances a patient suffers from addiction later. But Washington Democrats, they've destroyed all the momentum and made a bad problem worse. Addiction is a disease of isolation. And during the pandemic, Washington Democrats and Joe Biden promoted isolation and mandated lockdowns and mask requirements. It's hard to believe they suddenly care about substance use disorder today after keeping liquor stores and marijuana stores open as essential services while shutting down addiction support groups. Or after just last month, they proposed distributing free crack pipes to those suffering from the disease. The failure of Washington Democrats to address substance use disorder continues to hurt Americans. My district alone suffered over 350 overdose deaths in the calendar year during the pandemic. In the state of Missouri, we suffered over 2,000 overdose deaths, while our nation suffered over 100,000 overdose deaths. This made 2021 the deadliest overdose year for any country ever in history. This increase in overdose deaths is directly tied to the emergence of fentanyl, which is shipped from China to Mexico and then smuggled into our country through the gaping hole in our southern border. Fentanyl is deadly with 50 to 100 times the potency of morphine, and the cartels are mixing it with other drugs to make them even more addictive and dangerous. Worse yet, cartels are also producing lethal counterfeit prescription medications laced with fentanyl. Even without control in Congress, Republicans won't stop fighting to protect Americans from the threat of fentanyl. We've tried to pass legislation a month ago that would have made it illegal to use fentanyl in similar drugs outside of research purposes. But Washington Democrats, they blocked that legislation, even though the Biden administration recommended a similar strategy last September. We must empower our nation's law enforcement to stop fentanyl before more families have to bury their loved ones. Ms. Hulsey, could you elaborate on the harms of these counterfeit fentanyl pills, and would restricting the supply of fentanyl coming into our nation save lives?
Absolutely. Anything that we can do as a country to prevent fentanyl from being so prevalent would save lives immediately. We have fentanyl that we're finding in methamphetamine, in cocaine, in counterfeit Xanax, counterfeit Adderall, counterfeit opioids, and the effects are devastating. We have so many of our families who share the stories of someone taking what they thought was a prescription medication and maybe not from the right source, but they have a substance use disorder, and in effect it's poisoned. So we need more resources, more tools, all hands on deck to help us with the issue. There's a really good awareness campaign that the DEA put out called One Pill Can Kill. And so each and every one of us, everyone on committee, just to talk about this and make sure that people in your districts are aware of the prevalence of fentanyl and all substances in street drugs and counterfeit prescriptions right now would be a very helpful awareness piece.
Thank you, Mr. Chairman. I yield
Thank the
back.
gentleman. Let me recognize the gentleman from New York, Mr. Higgins, to inquire.
Thank you, Mr. Chairman. Substance abuse disorder continues to be a public health crisis, as we have heard. It affects millions of Americans, but as disheartening as the numbers can be, it's important to remember, as we heard from our colleague Mr. Reed, his compelling testimony, that there are good people and organizations that strive every day to help those recovering from substance use disorder. In my district in Buffalo, New York, Save the Michaels of the World is a not-for-profit that works to educate communities about substance abuse disorder and provide support and resources for individuals with substance abuse disorder and their families. Save the Michaels was founded by Avi and Julie Israel after their son Michael died by suicide after struggling with opioid addiction. When it comes to treatment and to treating substance use disorder, and in particular opioid use disorder, we know a great deal about what works and what does not. Medication-assisted therapy, of which 1.4 million Americans are now seeking, in conjunction with therapy and community supports, offers the best chance for folks recovering from opioid use disorder. Medication-assisted treatments are controlled substances, and we should be thoughtful and deliberate in how we regulate. But providers wishing to offer medication-assisted treatment face a complicated web of reimbursement and regulatory guidelines that can be difficult to navigate and can make medication-assisted treatments financially unsustainable. Diversion and abuse of medication-assisted treatments is a real concern, but evidence strongly suggests that if you want to reduce diversion and inappropriate use of medication-assisted treatments, the solution is to make them more accessible and get more patients into treatment. Dr. Chapman, can you speak more about your experiences with navigating the rules for administering and being reimbursed for medication-assisted treatments and how we can increase access to them responsibly and make the progress of administering, paying for, and disposing of them less confusing for providers? Dr. Chapman.
Thank you for that question. From my perspective, expanding medication-assisted treatment is going to be the key to curbing this epidemic. We know that opioids, unlike any other addiction, has a 90% relapse without treatment. And the problem is that it so closely mirrors our own endogenous dopamine system, our feel-good system. And we know now that there's a genetic component to it. A young person may break an arm or sprain an ankle and go to the emergency room, and with that first dose, feel different and feel that this is the greatest thing that ever happened. On the other hand, I'm allergic to morphine. So we can see that there's this wide spectrum of how each of us responds to these medications. So medication-assisted treatment needs to be available to anyone and everyone in the country. And we know from our experience that if we leave pockets of patients untreated, that drug suppliers and patients will find each other, so that we cannot leave any community untreated, any person untreated. So I think free access, similar to France and Portugal, where they had similar problems 20 years ago at the same time that we did, and they turned to medication-assisted treatment with methadone and buprenorphine, and there was a dramatic decrease in crime. There was a dramatic decrease in AIDS and hepatitis C, and of course, there was a dramatic decrease in overdose deaths. So we know from international studies that because of our system, our fragmented system, the fact that we don't have universal health care makes it very difficult for us to penetrate and replicate what we know works in other countries where they do have universal health care.
Thank the gentleman. Let me recognize the gentleman from South Carolina, Mr. Rice, to inquire.
Thank you, Mr. Chairman, for calling this very important hearing. Thank you to the witnesses for sharing their stories. This is certainly a topic that we need to do everything we can to tackle. The rise in drug overdose deaths is shocking by any measure. If you look at, I've been in Congress for 9 years, and I think every year we have adopted at least 1 or 2 or 3 bills to put more money into fighting drug overdoses, to adopt new programs to fight overdoses. The Support Act was certainly a milestone, and I'm sure all of them have helped at the edges, but I agree with Mr. Kelly that it just seems like we're attacking an iceberg with an ice pick, and that we're just chipping around the edges, and it almost seems hopeless. If you look at the numbers from 1999 until today, I mean, the graph just goes like this. I mean, almost straight up. And it starts out with the cocaine-type drugs, and then heroin kicks in and makes it rise further, and then finally synthetic opioids, fentanyl. And the reason for that is because fentanyl is so extremely cheap and it's so extremely available. A street dose costs less than $5. It shouldn't cost less than $5. Supply and demand, though, there's so much of it on the street that it's widely available to everybody, and it results in this straight up graph. And it mostly affects, it affects everybody, but it inordinately affects African Americans and people in poor communities. Last year, opioid deaths were 100,000 people in the United States for the first time. South Carolina last year, opioid deaths increased by 50%. 50%. The primary driver is vast, cheap, available drugs. I have a chart here from the National Vital Statistics System that tracks these deaths, and I'd like to enter it for the record, Mr. Chairman. If you look at this chart, interesting thing though, where it goes up almost every single year, actually it does go up every single year from 1999 until this year, except for 1 year. And that year was from 2017 to 2018. And then in 2019, it goes up, but not that much. And then with COVID, it starts going up radically again. Well, what was different from 2017 to 2018? What can we learn from that? If you look at our southern border, 90% of the heroin that kills people in the United States comes across the southern border. Cocaine, 90%. Fentanyl, we had 2,600 pounds in 2019. 94% of the fentanyl seized in the entire country was at the southern border. In 2021, it was 10,589 pounds. 95% of the fentanyl seized in the entire country was seized at the southern border. That's enough. That weight is enough to kill every person in the United States 6 times over with a single dose. Homicide. If you just don't look at the drug deaths and you look at the homicide deaths in the United States, 24,000 people were killed in homicides. I'd venture to say 2/3 of that was related to the drug trade, drugs coming over our southern border. Homicides have increased dramatically in the last 2 years as a result of the defund police campaign, increased violence, and the increased drug flow at the southern border. And these homicides obviously mostly affect poor communities. African Americans are 8 times more likely to die in a homicide. And then if you don't just look at our homicide, you look at Mexican homicides. 36,000 people in Mexico died from homicides, 6 times the rate of the United States. I'd venture to say 90% of those were related to the drug trade, cartels, and gangs, resulting in 36,000 deaths. So folks, this isn't rocket science. If you look at what happened when President Trump came in and we clamped down on the southern border, for the first time in 30 years, the number of drug deaths actually decreased. For the first time in 30 years. And the policy of the Biden administration to encourage people to come to the southern border, number one, and number two, to relax restrictions at the southern border is killing people. It's absolutely killing people. This is not a question, it's a fact. Just look at the graph. So I would say that so many of these programs and so many of these additional dollars we throw are chipping at the edges. If we really, really want to make a difference to the people who need it the most, if we really want to save tens of thousands of lives, we've got to increase our interdiction at the southern border. We've got to have a real southern border. We've got to seal it up. And Mr. Chairman, I yield back.
Thank the gentleman. Let me recognize the gentlelady from California, Ms. Chu, to inquire.
I'd like to thank the chair for holding today's important hearing and for continuing our focus on mental health issues. And I was so glad to hear President Biden address mental health last night. I look forward to soon introducing legislation with Representative Pascrell to close many of the gaps in Medicare coverage for substance abuse, including coverage for intermediate levels of care, expanding the list of eligible providers, and improving reimbursement. I welcome the support of my colleagues on both sides of the aisle on this legislation as we develop common sense solutions that help treat some of the most vulnerable Medicare beneficiaries. Dr. Riataza, thank you so much for being here. Thank you for your testimony and for highlighting the impact that the past 2 years of increased violence and abuse of Asian Americans has had on the mental health of our communities. Can you expand on how the rise in anti-Asian hate during the pandemic has influenced substance use in the AAPI population? Has your organization seen more outreach and need for support since the pandemic began?
Thank you, Representative Chu, for the question and acknowledging the need that our communities really face, especially during this time where there has been, as you mentioned, as we also discussed earlier, an increased rise in anti-Asian hate or violence directed towards Asians during this time. Yeah, we have seen an increase in stress and anxiety, and as well as just altogether mental behavioral health challenges and concerns that our communities are facing. Ultimately, people are afraid. They're afraid for their lives. They're afraid for their loved ones, especially our elderly and our women and our girls. And ultimately, that has resulted in an increased use of substances. We've seen a lot of increased use in tobacco and other things that can be smoked or inhaled. We also have seen some increased use in alcohol, and ultimately we've seen a rise, as I mentioned, in accidental overdose related deaths. I think that this is something that's been highlighted by a number of individuals already on this discussion, that we've seen substance use rise altogether. And I think even when it comes to stimulants and opioids, I believe it was Ms. Husley who said that, a lot of stimulants are even laced with opioids. And so there's been a lot of deaths related to those and in those capacities as well. I do want to remind a lot of us here that the opioid disorder was also driven by industry. That's something that I know is tricky to tackle, but we see it time to time, and we've seen it also trickle down in API communities as well. So yes, the short answer is yes, absolutely.
Dr. Riataza, I also wanted to follow up on the stigma AAPIs face in seeking behavioral health care, both from within our community and externally. That's why I introduced the Stop Mental Health Stigma in Our Communities Act, because of this barrier. And that is in addition to the linguistic and cultural differences that you noted in your written testimony. So can you discuss how bills like the Stop Mental Health Stigma in Our Communities Act can help increase access to care for minorities struggling with substance use disorders, especially in the AAPI community, and also how immigration status could prevent AAPIs from seeking the help that they need?
Thank you again for this very important question. And, everyone on this discussion addressed stigma today. I believe stigma is a huge barrier to addressing mental health, behavioral health, substance use, any kind of addiction, including problem gambling, which is also a big part of our community. When we're not able to talk about issues, either openly admitting them with our close family and friends or outside of our communities, it just doesn't get addressed. It doesn't get addressed. And when we can't address them, how do we know what the needs are? How do we know how to properly address them? And how do we know how to serve our communities in the ways that everyone on this panel is really striving to do? So I think, the bill such as this one, I think is an important one. I think this is important for AAPI communities. I think this is important for, really perhaps directing a model for all communities as far as how do we address traditionally marginalized and underrepresented communities on issues that are already really difficult to talk about and to address systemically.
Thank the gentlelady. Let me recognize the gentlelady from Indiana, Ms. Wolarski, to inquire.
Thank you, Mr. Chairman. Hoosiers have experienced firsthand the consequences of President Biden's open border policies that continue to wreak havoc in communities in my district. The administration's reckless disregard of our border security has spurred a plague of illicit drugs, including fentanyl, heroin, methamphetamine, and even fentanyl-laced marijuana that are being trafficked into local communities. This open borders approach is burdening everyone in my district, from families.
I threw in that immigration thing because I saw that it was hopeless.
And first responders to our workforce and child welfare system, and it's costing lives. The previous administration took meaningful steps to secure the southern border and reduce drug smuggling, but all that work has been lost. It's obvious that President Biden lacks the fortitude to stand up to the left-wing extremists in his party. Instead, he's stepping aside and allowing wicked drug cartels to prey on Americans. The scourge of these illicit drugs has a real effect on Indiana. Recently, a local fire captain in my district pointed out a warning that fentanyl-laced marijuana has caused a string of dangerous overdoses in our district. A local TV station in my district put together a 3-part series called Addiction and Michiana's Youngest Victims, in which they told the story of an infant who was brutally murdered by an adult who was entrusted to babysit her. Every murder case has multiple layers, but a major issue underpinning the eventual murder of this child seems to be meth and drug abuse by those who are responsible for her care. The baby's grandmother also believed that the 11-month-old was suffering from withdrawals from exposure to meth. This woman alleges that a sibling is also suffering from the ramifications of their parents' addiction. That's just one example. In another high-profile case in my district, a 4-year-old was tortured and beaten to death by his father. While the murder of this child also has many layers, there is still a common theme. There was drug abuse in the home. In an interview, the child's aunt, who was fighting to gain custody, often worried about the child's well-being and told the news, quote, because of the drug use and the way their relationship was very toxic, and the way they live was filthy. Children in Indiana and across the country are suffering from the ravages of drug addiction. We need to take a strong bipartisan approach to protect children and help individuals get on the road to recovery. However, we will not be able to get to that point until we stop the flow of drugs coming across that border and into our own communities. Ms. Halsey, you mentioned the ACE intervention programs and the START program in your written testimony. Both try to address substance abuse disorders within the child welfare system. Do you have recommendations on how we can move coordinated interventions upstream? And then how can we protect children from abusive parents with substance abuse issues while also helping to get those parents into recovery programs?
Thank you so much for highlighting this. This is such a critical part of our solution. I'm a grown-up now, but I was a kid impacted by parental substance use disorder. And so I've seen firsthand the difficulties that parental addiction can create. There's some amazing programs and innovations that are out there. Kentucky START is a child welfare intervention. It's also in Ohio and several other jurisdictions now, where teams work with both the parent as well as the children to increase sort of keeping the kids in home, but also making sure we're addressing recovery, evidence-based treatment and supports for children. Kids who've experienced adverse childhood experiences, childhood trauma due to parental substance use disorder, also a high priority. There's a program in Essex County, Massachusetts, that works with the school system, with the middle school and kids that have addiction at home with high ACEs scores. It has social emotional learning curriculum, connection to counselors and behavioral health care. And the results of this program are tremendous. Sort of higher graduation rates, lower substance use. The kids are heading off to college. District Attorney Jonathan Blodgett led and set up that program 7 years ago. So we have the solutions. We know that this is one of the most important populations to work with. We can implement things that address this really critical time when someone in a family is involved in child protective services due to an SUD. And we can also have better screening for all children with adverse childhood experiences to get them the care that they need.
Can I ask
No
you one more
child is
question, Ms. Halsey,
unsavable.
before I run out of time? Homeless youth is another problem I'm sure we're all encountering. Are there any programs out there right now that connect homeless youth with substance abuse services offered at federally qualified health centers?
I'm not aware of any specific programs, but we're happy to connect with our network and report back to you.
I appreciate it. Thanks. Thank you, Mr. Chairman.
Thank the gentlelady. Let me recognize the gentlelady from Wisconsin, Ms. Moore, to inquire.
Thank you so much, Mr. Chairman. And I just want to thank all of our witnesses for participating in this very important hearing today. I do want to thank Mr. Reed for sharing his very personal story and really helping us move toward a point where the stigma of substance abuse is no longer there, and that we can work on this systemically. Mr. Kelly talked about us dealing with this problem like chipping away at an iceberg. And I say that similarly, it's sort of like grabbing a problem that's sort of like Jell-O. And I really appreciate the fact that most of our witnesses have really at least helped me appreciate that we've got to start young and sort of deal with, delaying the onset of use of substances, and that we need to be careful with our brain-injured athletes, foster youth, and others. This has been very informative. Dr. Chapman, I appreciate your bringing up the importance of having social workers involved. I've every year that I've been here put in a bill to try to have social workers in our schools so that we can identify these problems early on. That being said, let me direct my first question to Dr. Metzel. You talked about structural competency, but you also talked about how there's no magic bullet, that there's a myriad of factors that contribute to it. So we've got the poorest of the poor who are subject to it, but then you have the rich kid on the hill. And I fear that we hear, it's all about the southern border, and if we could just fix that, then we would no longer have substance abuse. I'm wondering, I was curious about your truth and reconciliation provision under structural competency. How do you see truth and reconciliation as really helping us prioritize where to put the resources that we have? And also, I think that we heard Dr. Rayataza saying that we have to bring stuff up to scale. So what should we bring up to scale? So I would ask Dr. Metzel and then Dr. Rayataza to talk about what we can bring up to scale that would help us with this problem. So I would yield now to Dr. Metzel for his answer.
Well, thank you so much. Really wonderful question, as these all are. I would say that I wish there was an easy answer. I wish we could say that it was this one policy at this one moment in time. But unfortunately, when we look at substance abuse issues and depression and suicide, what we see is that these are the result not of something that happened in a particular year because of a particular decision, but because of longstanding neglect about support system, about infrastructures, about factors like that. Now, just to be clear again, I'm all for doing anything that will help here. But I think especially when you look at the impact on communities of color, what you're seeing is that really there's a long-term neglect of all kinds of infrastructure, health infrastructure, support infrastructure, substance abuse treatment, factors like that go hand in hand with economic inequity, particularly in urban areas.
So let me make an intervention here. Are you saying that these poverty indicators make you more at risk than, say, the rich kid on the hill or, Prince or Michael Jackson? Would you say that poverty and inequality is more indicative of risk?
Directly, yes. I cite several references in my written testimony that support that point. Now, again, this cuts across many different avenues, But I certainly would say that economic despair is one part of it. And then you mentioned you referenced a paper that we wrote for JAMA at the beginning of the pandemic. And what we did was we kind of called for an open, honest conversation about the structural upstream drivers that are producing despair and in unequal ways. But linked to one of the comments that we had before, we also called for reimagining healthcare clinics, not just telemedicine, but actual healthcare clinics where people could go to the clinic, and that clinic would not just treat their medical conditions and their substance abuse issues, but also there would be resources within particular clinics to address issues that cause a kind of structural vulnerability. So you could have a clinic with an internet provider, with somebody, a resource for helping people pay their heat bill, for access to all other
Thank you,
treatments.
sir. Dr. Rayataza, what should we bring up to scale that you think would be most helpful?
I appreciate this question. So I think what we really have to understand is, why do people resort to substance use and why do they get addicted to substances? There are a number of issues that we're not addressing as far as safety net, really caring for our communities. People don't have appropriate access to healthcare, to childcare, to job training. A lot of people don't have a livable wage, stable housing. We really have to address all of these issues that, one, impact people socioeconomically, but also when we're looking at ethnic and racial disparities. And we've seen it, that these are also issues that combine together as far as what we are seeing as far as trends, on a local and also national scale with substance use and other addiction kind of behaviors.
Thank you so much. My time has expired. Thank you, and I yield
Thank
back.
the gentlelady. Let me recognize the gentleman from Ohio, Dr. Winstrup, to inquire.
Thank you, Mr. Chairman. Thank you all for being here today. This is a very important issue, very important to my district. I'm glad we're discussing substance abuse, mental health. The pandemic has fully exacerbated these conditions in my mind. The last hearing we had here in Ways and Means, I touched on a couple of stories. One about a veteran, a double amputee, and his last Facebook post was an empty refrigerator and a couple bottles of water, and then he took his life. I've shared a story about a gentleman from my district who was scheduled for his painful hernia to be operated on, and they canceled his surgery, and he took his life. The isolation, the pain, the lack of treatment. A lot of lessons learned, I'd say, through this pandemic. And one of the other things that bothered me through this pandemic is when we told some people they weren't essential. I think that had a big impact on a lot of people, to be told that, well, you're essential, we need you, we essentially don't need you. So we made a lot of mistakes. And in addition to the pandemic, the current border free-for-all is a part of this, and I'll get into that in more detail in a minute. And that empowered the cartels to go ahead and continue and exacerbate and grow their business, if you will, of human trafficking and drug trafficking. If you've read the book Dreamland, which I imagine most of you have, that's my district on the cover. So I know firsthand all the effects of what has been taking place. And I like to describe the problem that we have in America today with this is a problem that goes from our border all the way to work or purpose. So you do have a problem with the border with drugs coming across there. The supply chain is great. We should do what we can to stop that, everything that we can to stop that, and then stop the dealers that are running around our country. And then we have to take with our youth and everybody else and prevent people from ever getting in that situation. I'm a doctor, a surgeon. I never thought that those drugs were not addictive. I always felt that they were. I never prescribed OxyContin for my patients. And as a surgeon, I managed their pain in a lot of other ways and limited use of opioids. So there is an onus on the medical community too, and I think the medical community has responded to this. But we need to do more than just catch and release. When someone goes into rehab, that's a good thing, but there has to be something at the end of that. There has to be a purpose, there has to be a job, or else they're going to end up right where they are. So it's all encompassing of what we need to do to address these problems. And I'm grateful for the hard work of some of the folks in my district, like the Lindner Center of Hope and the Hamilton County Addiction Response Coalition. They've done some great work. 2018 passed Bipartisan Support Act, the ALTO bill, which is alternatives to opioids in the emergency department, and really throughout medicine is what we should be approaching. But I think at the end of the day, we need to always address the events and the issues in someone's life that led to the thoughts and the feelings that led to the behavior. And if we don't do that, we may never solve these issues. So as we try to be supportive of trying to solve these issues, you know, one question I would ask to Ms. Halsey, are there provisions in the Support Act that don't apply to fentanyl, for example, that we can update, or other things within that act that we can update to address some of the heightened challenges that we have today?
Yeah, absolutely. I think both CARA and the Support Act were such important pieces of legislation with new policy changes and resources to improve treatment, and support really helped us integrate treatment into the healthcare systems. Fentanyl, looking at different treatment options, making sure we have medication for opioid use disorder more widely available, making permanent some of our telehealth expansion pieces and the wraparound services that are needed. It's not just one thing that an individual in treatment and recovery from an opioid use disorder needs. They need wraparound care, and it's management of a chronic health condition. So looking at support and new vehicles to add more of that, I think would be a huge benefit to our patient population.
I appreciate that, as you heard me go through all those components that lead to the situation that we are in, that the patient is in. We do need more wraparound services, and I appreciate the input, and I yield back.
I thank the gentleman. Let me recognize the gentleman from Michigan, Mr. Kildee, to inquire.
Well, thank you, Mr. Chairman, for holding this really important hearing and for the focus on this issue. Like others, I want to share a bit of a personal story. Last year, I publicly shared that I began receiving treatment to help with traumatic stress that I and a number of us have experienced as a result of the attack on the U.S. Capitol. And I was in a unique situation with a few other members who were trapped when the insurrection occurred, and we were in a violent situation that had an effect on me. I didn't expect it to, but it did. But I'm lucky, you know. I've got access to a great professional, Dr. Jim Gordon, who has been working with me on, you know, the techniques and skills that I need to deal with stress. I went public with that because I felt it was a small opportunity for me to help reduce the stigma of mental health care. But despite the improvements in the understanding of the importance of mental health and mental health care, that stigma still persists and can manifest in stereotypes, prejudice, other aspects, some of which I heard, but you know, in our business, we expect those sorts of attacks. For someone who's dealing with a mental health issue privately, quietly, painfully, that stigma can keep them from making the choice to get help. And we know that a lot of people struggle with issues and never do get help. And we know, sadly, what sometimes the result of that will be. Access to health care is a huge factor, but the stigma plays a role too. So I wonder, and I know this has been addressed, but I wonder, Dr. Metzel, if you might talk about how U.S. policies may have stigmatized care for mental health or substance use disorders, and help us understand from your point of view what we should and can be doing to reduce stigma associated with mental health among communities, among healthcare providers in particularly, but just generally in the population.
Well, thank you so much. What a wonderful question. I'll make 2 points in response. First, of course, you talked about traumatic stress, and it's important to note that traumatic stress results when people feel like their lives are in danger. The initial PTSD studies were done with fighter pilots in Vietnam. If you flew 10 hours of sorties, you had a 10% chance of getting PTSD. If you flew 40 hours of sorties, you had a 40% chance. And then think about it. We've all gone through this pandemic where just stepping outside the door and breathing the air that other people breathe put us all at risk. And so I feel like even though some people are, like yourself, involved in direct conflict, I feel like there's a national moment of stress where we've really had to rethink our own being, our own vulnerability, because we really had to ask what is a safe space. And so number one is to, as I was mentioning before, create a national conversation about what mental health means, where we can have an open, honest, bipartisan conversation just about the trauma that we've all been through over the past 3 years, and think about ways to come together. And I really think that that's vital to reimagine what mental health means in this context. And the other part, of course, is that fighting stigma is an ongoing battle. I wrote a book called The Protest Psychosis about Michigan, actually, that came out a couple of years ago. And it looked at how unknowingly the diagnosis of schizophrenia during the 1960s was reflecting cultural attitudes about political protest, about incarceration, all these factors. Doctors thought they were helping people, and they were in certain kind of ways, but just the idea of what mental illness was reflected cultural attitudes about politics, about race, or factors like that. And so the second point I would make is that fighting stigma is an ongoing battle. It's not just like, here's this one thing we have to nip in the bud. And so as much as we can be active about it and continue to engage with our own reflections and have, again, a national debate about this, I think the better off we'll be in the long run.
Well, thank you for that. And I wonder if I might just quickly pivot. You know, I represent two communities, Flint and Saginaw, both majority-minority communities, both, historically marginalized communities. In Flint, especially, having now gone through this pandemic, and also the trauma of a spate of violent crime that has gone back decades, and in Flint, the water crisis. I wonder if either Ms. LaBelle or Dr. Chapman might comment on community issues and on sort of how we deal with these historically marginalized communities who, as a community, may be dealing with community trauma and impacting addiction and illness as a result.
Thanks for that question. About 2 or 3 years ago, the Lancet magazine put out an article evaluating communities, actually automobile assembly plants. And they found that 5 years after an assembly plant closed, that there was a dramatic increase in opioid use disorder and alcoholism. So we know that there's a close association with economics, the stress from not having a job, et cetera. The same thing happened in Cecil County, Maryland. The automobile assembly plant in Delaware closed, and 5 years later, there was a dramatic increase in foster care. And this was noticed by a state trooper. Happened to be evaluating some of the schools, and he looked in the schools and realized that there was a 30% increase in foster care. And the fact was that the parents had overdosed and died. So all of these things are directly connected.
Well, thank you. And I'd love to get more information. Mr. Chairman, you've allowed me to go beyond my time. I appreciate that, and I yield back.
Thank the gentleman. Let me recognize the gentleman from Texas, Mr. Arrington, to inquire.
Thank you, Mr. Chairman. Let me dive right in on the drug addiction and the illicit drug epidemic we have in our country right now. It boggles the mind what's happening and what our nation and the people's government is doing or not doing to stop a major contributing factor to this epidemic in our country. We have lost last year 100,000 Americans to drug overdose. The leading cause of death for Americans age 18 to 45 is a drug overdose, mainly fentanyl, which is 2/3 of the contributing drug to the overdose. And 100% of those drugs are coming from across the border. The 100,000 people who have lost their lives in our country, our fellow Americans, is a 50% increase over the last year. The fentanyl seized at the border is up over 130%. We're losing a generation of Americans to this epidemic. And we're seeing record volumes, increasing exponential volumes of drugs continuing to flow into our neighborhoods and to kill our fellow Americans and our family members. And we're seeing nothing stopping the drug cartels who control the border from pushing this product onto our citizens. I'm going to ask every witness to answer this directly and succinctly with a yes or no. Is this dynamic of drug cartels in control of our border, pushing record volumes of drugs, a major factor in the drug epidemic and the overdoses that are at record highs in the United States of America? And so I will start from the very top. I'd like to hear from these experts as to whether or not it concerns them. So does it concern you? Is it a contributing factor on the supply side? At a minimum, yes or no? Dr. Jonathan Metzl, yes or no?
That is not a yes or no question. Certainly, of course.
Okay, let's go to, no,
concerned
Dr.
about the
Metzl, thank you. It is a yes or no question. I'm not saying there aren't other factors. I'm not saying there aren't more complicated and nuanced discussions to have. But is the border wide open, pouring drugs that are killing Americans at rates that defy logic because of our ability to stop it concern you? Yes or no? Is it a concern?
Certainly, supply side is a major aspect of addiction. I would certainly agree with that.
And not to be rude, thank you, we're going to move on. Dr. Edwin Chapman, you're a physician. Is it a concern what's happening at our southern border? It's one factor, but is it a big one? And are you concerned, yes or no?
I think it's a chicken and egg phenomenon. I grew up in Gary, Indiana in the 60s, and we didn't have this problem until the steel mills closed, and then the city.
Are you concerned,
went down.
Mr. Chapman, does the open border concern you and the drugs flowing across the border via the drug cartels that are in control of the border? Does that concern you?
We have new synthetics now.
The synthetics are coming from China, and the synthetics are coming from China, Mr. Chairman, and they're part of the input to making this manufactured product. It's being laced with the marijuana that kids are taking up in the Northeast, killing teenagers. This is a big deal. The fact that, and look, I respect these witnesses, and I know they care about this, but the fact that they can't just say yes, what's happening at the border and all of the volume of drugs that are coming from across the border by the cartels with aiding and abetting by Chinese synthetic materials is I just can't believe it. I can't believe I'm sitting here with nobody to bang the table and say, you're right. We can talk about other issues, but you're right.
I mean, I don't intend to speak for the witnesses, Mr. Harrington, but I think that we're all concerned. I think that the witnesses have suggested that there may be additional answers, but I think everybody would preface their comments by saying we're all concerned about it.
And Mr. Chairman, I know my time's expired. As a person who lives at a state that is on the border and at ground zero, I'm telling you, we've got to do something about that. I know there are other complicating factors, but we've got to do something. And I'm very frustrated that we haven't. Thank you, Mr. Chairman.
Thank you. Thank the gentleman. Let me recognize the gentleman from Virginia, Mr. Byer, to inquire.
Mr. Chairman, thank you very much. And Mr. Chairman, thank you so much for having this hearing today on suicide risk and substance use disorder. I'm so proud that we're having a hearing where suicide is actually the headline. Suicide rates in the U.S. have increased by 35% over the last decade and remained high during the pandemic, with nearly 46,000 people dying by suicide in 2020, more than the toll of car crashes and gun fatalities combined. When I entered Congress in 2015, suicide wasn't talked about by members except in reaction to the veteran suicide crisis. Folks knew we had a veterans issue. We also had an active suicide crisis in the broader population. Even then, we were seeing a 30% surge, and no one was talking about it. I chatted with Representative John Katko, Republican John Katko, and Democrat Grace Napolitano. And John and I started the Suicide Prevention Task Force and Grace's Mental Health Caucus to improve suicide prevention on the civilian side. We focused on restoring the suicide line at the CDC, tackling the glaring issues we knew we could help with, like the Suicide Lifeline, which was under-resourced and couldn't keep up with demand. We restored the suicide account at CDC and slowly been able to work to allocate more funding to the Lifeline. We helped Representative Chris Stewart, a Republican, Seth Moulton, a Democrat, in their efforts to change the Lifeline number to the Easy 3988 number, which goes live this summer on July 16th to be exact, and I hope everyone will remember that. And during May Mental Health Month last year, Energy and Commerce advanced a mental health package that included a great number of suicide prevention bills, including the Campaign to Prevent Suicide. This is a bill that Republican Adam Kinzinger and I put together with the goal of a bipartisan effort to educate the public about the 988 number so that people know about it, but also generally to change the culture around suicide so that people know how to engage and connect individuals in crisis to resources. Unfortunately, the House is taking suicide prevention much more seriously than the Senate, and much of that bipartisan legislation is stalled in the Senate today. So I just want to use a little bit of time to draw attention to the fact that the Senate should not delay. We've got to advance this House-passed legislation as soon as possible. Dr. Metzl, I was fascinated in your written stuff that you talked about polarization as a national health crisis. You said divisiveness is a vector that weakens our nation in moments of crisis. Eminent bodies like Congress can change the algorithms and structures that foment divisiveness and replace them with structures that model unity and value cooperation over competition. I just looked at the difference in the opening statements, the tone and content of our chair and our ranking member today. I don't want to blame all divisiveness on Republicans. That wouldn't be fair. But can you talk more about how our divisiveness is affecting the American people and their mental health?
Sure. I mean, there is so much research from other points in time, other historical precedents that talk about how when we face a crisis, a pandemic, an epidemic, one of the most important currencies that you can have is what's called social capital or social cohesion, this notion that we're all in it together. Now, I realize that our political system is kind of a zero-sum formulation. It's a winner-take-all election system. Compromise is very difficult, but what happens a lot of times is that issues around which we should all agree, things like mental health, like we're talking about today, addiction, they become polarized and identity issues in a kind of way that might make sense in a political arena, but when they filter down, they really become moments of discord and despair, which can directly lead to poor mental health because people feel like they're literally fighting with their neighbors. And certainly I think President Biden was right last night that is fomented by some of the algorithms on social media. And so when I was writing my written statement, thought, what are the ways in which we can think about polarization itself as being almost a crisis moment? And I thought mental health was one of the areas where we might actually figure out where we can come to some kind of common agreement. And I have much more to say about suicide. That's my research, but I'll save that for later.
And Dr. Metzl, I only have a couple of seconds left, but more than half of suicides are gun-related. 2/3 of gun deaths are suicides. And yet, my Republican friends have an aversion to recognize the realities on the ground, how easy it is for a person in suicidal ideation to get access to a gun. This would be a great place to start to overcome that divisiveness. Any ideas how we move forward?
Absolutely. Much to say about this. That's the focus of a lot of my research. What's important to know about gun suicide, we have 27,000 gun suicides a year. It's very often an impulsive act, not someone who's been seeing a therapist for 25 years. I was drunk, I lost my job, I found out, something happened in my family, and within 59 minutes or less, the availability of a firearm is there, and that leads to gun suicides very often. And so having urgent resources, a hotline at that moment, some access to help in that moment, that passing moment of crisis is vital. That really gun suicide is a different kind of suicide. That's what I argue in my work. And we need urgent resources that are available in those moments of crisis.
Thank the gentleman. Let me recognize the gentleman from Georgia, Dr. Ferguson, to inquire.
Thanks, Chairman. And listen, I want to go back to the topic that my friend from Texas, Mr. Arrington, touched on. First, let me say, addiction is an incredibly difficult disease. I have been involved with that, both from a healthcare provider standpoint and as just a general member of a community, and it is devastating. And one of the key components is the supply of drugs. And I think my colleague from Texas asked a really, really important question. You know, can we all agree and can we objectively say that the drugs flowing across our southern border are a major problem here? This is devastating. And I want to continue down and ask Ms. LaBelle, do you agree that this, yes or no, that this is a major problem at the border? Can you objectively say that drugs flowing across our southern border is a major problem?
Thank you, sir, for that question, because I think illicit drug trafficking is an international problem, and going after illicit finance, as well as making sure we have protections at the border, is the way to approach it. It's a comprehensive approach.
Right to going down. Again, this is a major problem, and we've got to objectively look at where it's coming from, and we've got to objectively look at the problem, and we've got to secure our southern border for a lot of reasons. Human trafficking, the illegal immigration, but this drug issue is so serious in our communities. I want to change gears and want to talk a little bit about the mental health issues that our school children are seeing, not just in K through 12, but also in college. And Ms. Halsey, I know you have you've been able to dive into this. I introduced a bill last year called the BIG Act, which is an early intervention bill, helping universities and schools put together best practices on how to engage very early on with students. Can you talk a little bit more about what we should be doing in that arena? And also, could you touch on the importance of telehealth and also not only training more providers in this area, but also the resources that we need to be giving those in our education community to recognize these problems at an early time?
Thank you so much. Absolutely. Early intervention, all programs and research-backed solutions that we can dedicate to middle school, high school, college-age young adults. These are the ages when typically it sort of coincides with the onset of a substance use disorder. And so the fact that we delay and don't have proper early intervention mechanisms in place is a huge gap in our system. We have them, we just need to implement them. Things like screening, brief intervention, student assistance programs that deal with ACEs, helping children impacted by addiction, primary and universal prevention to help us delay the onset of substance use. All of these are critically important. I think your second question was about telehealth. Absolutely. The more access we can open up, the better to all different types of providers, from psychiatrists, psychologists, counselors, peer navigators. We need more access. Would love at some point to tackle some of the licensure issues that we have across state lines. We could really open up the amount of workforce we have available if we looked at this maybe from a different lens. And then on the provider side, retaining and training and looking at the pipeline of those that are coming into the addiction workforce is incredibly important. Our workforce is paid less than other healthcare professions with the same training and education. And so we need to dedicate, I think, resources and time to figuring out how we have a plan for the clinicians that we need long-term.
Okay, thank you, Ms. Halsey. Going back to the, to this topic in dealing with early intervention in schools, I just feel like that this is so important that we focus on this, that we get the early signs, we get the children and the young adults the help that they need very early on. And I realize it is a multifaceted event. We're dealing with social media influences. We're dealing with the isolation that's occurred during COVID and the lockdowns. I have a high school senior. I can tell you the impacts on him have been very real, and I see that with not only him, but his friends. So, and I truly believe that we can't solve this issue in rural America if we don't have access to broadband and we don't have access to telehealth services. That is just something that we have got to get right in all of this. So with that, Mr. Chairman, I yield back.
Thank the gentleman. Let me recognize the gentleman from Illinois, Mr. Schneider, to inquire.
Thank you, Mr. Chairman, and I want to thank you and the ranking member for having this hearing, our witnesses for joining us today, and for your commitment to patient care and your perspectives you bring here. I want to thank the committee for continued discussion on a very challenging and important subject. Dr. Metzel, I think you made a very important point in your testimony. Addiction, depression, and suicidality do not discriminate. But as you note, and as we have discussed today, there are groups with particular concentrations, in particular veterans and young people. And as we all know, the pandemic has led to a spike in stress, depression, addiction, and tragically suicide. I'm sure each of us here today have many personal and often tragic stories. We've heard some of them today. Just last month, a dear friend of mine got a call every parent fears. Orly Sheffy was a vibrant, smart, beautiful 19-year-old. Her name means my light, and it perfectly describes her. Not one, no one, not her family, her friends, her teachers understood her anguish. If we did, we all would have done what we could to try to help. Everyone's challenges and experience with mental health are unique, and sometimes there are clear signs that people need help, but lack confidence to seek it out or know where to find it. And other times, like in Orly's case, there are no flares or warning signs that any of us could see. Sadly, in Illinois and around the country, too many people are unable to find the help they need. Long before this pandemic, we faced shortages of the resources necessary to care for those who are struggling. In the United States, we've seen an increase of suicide rate by 35% over the last decade, and nearly 46,000 Americans died by suicide in 2020. That's an average of nearly 300 people a day in the United States who die every day to drug overdose or other struggles. To me, these statistics indicate that we need to be more aggressive about dealing with these crises. During last month's hearing on the mental health crisis, I emphasized the need for more mental health resources, better education to increase awareness and remove the stigma for asking for help, and smarter reimbursement policies for mental health providers and services. I reintroduced my Substance Use Disorder Workforce Act last year to increase the number of Medicare-eligible residency positions eligible at hospitals that have addiction, psychiatry, or pain medication programs. This is one real way to help deal with the ongoing staff and resource disparity in behavioral health services, but we must continue to do more to expand these services. While we can't always recognize the signs, we must empower adolescents and adults to feel brave enough, confident enough to reach out for help. And when people do, we have to ensure that there are mental health services and trusted, reliable resources waiting on the other end at the Suicide Prevention Hotline, which thankfully soon will be a 3-digit crisis 988 number this summer. We must also recognize the challenges certain populations face, like African American men dying from increased rates of overdose, or white Americans who represent 92% of all gun suicides. So now I get to ask a question. Let me turn to Dr. Reyataza. Last year, I received a letter from a high school senior outlining her findings on the disparities of mental health resources at her school. She highlighted the value placed on new gym flooring and new scoreboards, but the lack of investment in mental health counselors. She shared that they lost a classmate earlier this year to suicide. I also became more aware of so-called suicide websites and social media influencers on our children's mental health. Can you please explain how stigma and chronic disinvestment in school-based mental health services can lead children to turn to some of these websites, and what we can do to better understand or support mental health for school-age children?
Thank you, and I appreciate this very, very important question. This was something that I constantly worried about when I was teaching high school, and it was something that also personally impacted me. When I was in high school, one of my friends and classmates also committed suicide during spring break, and it impacted all of us. I think overall, when we think about what's happening in schools, our children spend the most time at schools, and if we don't have services that students feel safe accessing, and that can come in a lot of ways. It's yes, we need more counselors, but we also need to be able to work with our teachers, our educators, in the entire workforce at schools to be able to address at-risk youth if there's any kind of suspicious behavior to your question about, or not suspicious behavior, but potentially dangerous behavior, which involves yourself. With regards to access to social media, I think that social media is a big concern among youth because I think that it paints a picture that that can be damaging, and if we don't have the appropriate awareness or regulations on damaging social media and access to that, if youth are accessing those and we're not addressing those in a way where we can. Sorry, let me come back to my words here. The issue is that when we have websites like these that go unmonitored and we don't have a way to actually discuss with our youth what the issue is, these issues continue to be stigmas. They will continue to be stigmas. We will continue to fail addressing them, and we will continue to see these deaths come together. And unfortunately, sorry, I'm
No, you're
kind of
fine.
struggling
You're
with my
fine.
words today.
We'll just finish up there.
This is my first hearing, so
You're doing great. Let me assure you, you've done great.
So, I think overall, we're not having the conversation. We're not having the conversation, what's really happening and what students are seeing at home and at schools, what they're talking about with their friends, what they're seeing at social media. Okay. And if we can't talk about these things overall, this stigma will persist and it'll continue to harm all of our communities, especially our youth.
Thank you,
and thank you, Chairman, for the extra
Thank you.
time.
I thank the gentleman. I'm glad that our witness mentioned social media. That's a very important consideration here. Let me recognize the gentleman from Kansas, Mr. Estes, to inquire.
Well, thank you, Mr. Chairman, for holding this very important hearing, and thank you to each of our witnesses for joining us today. As we talk about the tragic rise in mental health issues, including cases of severe anxiety and depression, and the rise of substance abuse disorders and suicide, I hope that we can address the underlying causes behind the rapid decline in our nation's mental health. Also hope that we can address why we're seeing so many of these dangerous drugs become so widely available across so much of our communities. In Kansas, the first half of 2021 showed methamphetamine accounting for 44% of overdoses. The wide dispersal of this and other dangerous drugs like fentanyl is destroying families and whole communities across Kansas and across the country. No matter how much some of us here want to ignore the crisis that we're facing on the border, the fact remains that illegal drugs are pouring in. The number of fentanyl deaths has doubled in 30 states in the last 2 years, 5 of which saw a 5-fold increase. The DEA has confirmed that Mexico is one of the primary sources for the flow of fentanyl in the United States. Just this past week, Border Patrol officers seized close to $3 million worth of meth disguised as onions. I'm proud to say that our Border Patrol caught this shipment, but much too much is being missed. Without proper enforcement of America's laws at the border by this administration, the substance abuse crisis and many other associated crises will only get worse. In Kansas, we've heard our law enforcement sound alarm bells over the rise in crime linked with drugs, especially with meth. In Sedgwick County, Kansas, my home county, it's reported that 70% of all drug crimes involve meth. While there is assisted treatment for those addicted to opioids, resources for those struggling with methamphetamines are scarce. So as we talk about the horrible rise in drug overdoses and suicide, I think it's time to recognize the fact that many of the measures that are clearly causing the issue must be addressed. Ms. Holsey, in your testimony, you mentioned the importance of increasing the availability of Medicaid-assisted treatment, MAT. Unfortunately, MAT does not exist for meth addiction. Is there something that should be further explored through research?
Absolutely. Top of my wish list every year is a medication to treat stimulant use disorder. As having my dad struggled with both opioid use disorder and stimulant use disorder, crack cocaine, and it's a devastating illness. We need more tools in our toolboxes. But yet we do have contingency management, which is behavioral therapy proven to work for stimulant use disorder, for cocaine and methamphetamines, vastly underutilized in all of our communities across the country. So yes, we need more tools, and yes, we need to actually use the tools that our researchers and clinicians and scientists have already built for us.
So you talked about contingency management. I mean, what are the barriers to being able to use those services? I mean, is it cost prohibitive? Is there too great a demand? Are there too few individuals trained in the services?
It's a great question. We could use your help with eliminating some of the barriers around contingency management. Yeah, contingency management, it's beautiful because it uses sort of incentives, the same sort of part in your brain that's affected by addiction. It's sort of using it against the disease. So you're incentivizing positive behaviors through rewards, through a gift card, through incentives that keep someone retained in their program and participating in the behaviors that we need to see. There's prohibitions on using federal money for contingency management that we'd love your help to address. We have a lot of stigma around these programs, and it shouldn't be there. When we can incentivize and we can build these programs and this behavioral therapy into all of our treatment, you can even use contingency management through digital therapeutics now, I believe. We can improve and layer interventions that work. Let's say even someone who's on MAT, contingency management can still be used in concert with that, along with cognitive behavioral therapy and counseling and other supports. So yes, there's some barriers. We'd love your help eliminating those, particularly with the increase in cocaine and methamphetamine overdoses. We should be doubling down on the availability of CM.
Well, thank you. And Mr. Chairman, again, thank you for holding this important hearing. There are too many Americans that are suffering right now, and we can't continue to rely on our jails and our hospitals as a place of last resort for folks that need help.
Great
Thank you,
point.
and I yield back.
Great point. Thank the gentleman. Let me recognize the gentleman from California, Mr. Panetta, to inquire.
Great. Thank you, Mr. Chairman, and thanks to all our witnesses. I think, beyond this hearing, I think all of us have seen over the last 3 years what the pandemic has done and the toll that it's taken on our nation's mental health. But obviously, for many people, including many in my community on the Central Coast of California, it's exacerbated longstanding problems. For the past 3 years, basically, they've laid bare to the challenges facing our healthcare system, our first responders, and many of our most vulnerable and underrepresented communities. So obviously, thanks to all of the witnesses today for sharing their time, but also their expertise. I'm hopeful that this hearing will help us better serve our many diverse communities and our youngest constituents who've often been the victims of the substance abuse epidemic. Dr. Riataza, you're doing so good in this hearing. I'm going to continue to ask you a couple questions, if that's all right. Obviously, in your testimony, you mentioned that suicide is the leading cause of death among Asian Americans aged 15 to 24. Absolutely alarming, if you ask me. In California, as you probably know, 3 in 10 Asian Americans reside there. That's 17% of my great state. Now, these communities face unique stigmas and stressors that really increase the rate of youth suicide and make mental health outreach much harder. In your testimony, you also point out some barriers to care that are common across the AAPI population. And you make it clear how much diversity there is between AAPI communities and cultures. So my first question is, can you disaggregate some of the cultural barriers to care in different AAPI communities? And are there any communities in particular that we got to do a better job reaching out to? And if so, how the heck do we do it?
Thank you, Representative. And thank you for being gracious on, my fumbling my words. I really appreciate it so much. Yeah, I think that it's very clear, even within the AAPI communities, that there are a number of ethnic groups and sub-communities that are constantly and consistently marginalized. And so, for instance, I mentioned Native Hawaiians and Pacific Islanders. The Pacific Islander community as a whole are generally a smaller proportion of the larger Asian American, Native Hawaiian, Pacific Islander umbrella. And because of that, a lot of their needs and priorities actually don't get met because the studies aren't done, the data isn't collected properly, and then because that's not there, we don't have the accurate reports to actually reflect what's happening. Other things that impact our communities very much, and I know this is an issue that doesn't just impact APIs, is immigration. You know, a lot of us also come as immigrants here. And as far as immigration is concerned, specifically, a lot of Southeast Asians have undergone tremendous amounts of trauma that involves like war, authoritarian rule, poverty, famine. And a lot of these issues are very specific to our communities. And in those instances, in these ethnic groups specifically, like, I'm talking about the Cambodians, Thai, Lao, Hmong, Vietnamese. There's a lot of issues that we're not seeing, and personally in my community as Filipino Americans, colonialism is something that we've really still been trying to heal from as well. And so I come back to the question of disaggregation. How do we better address these communities? Well, in part, we've got to do a better job of addressing actually what's going on. We have to be very intentional in how we are collecting data, how we are doing it with communities, in partnership with communities, and then also reporting back, because I think what happens oftentimes is this data doesn't actually come back to communities, or there's a long stretch of time before it's actually published. And what happens is time changes and needs become different, and those populations that were already marginalized or not reported upon have already had different needs. And so I think there's an urgency that we're trying to address here with data disaggregation, that it must be done urgently and thoroughly.
Great. Thank you. Outstanding articulation and an outstanding answer. Thank you. Thank you, Mr. Chairman. I yield back.
Thank the gentleman. Let me recognize the gentleman from Oklahoma, Mr. Hearn, to inquire.
Thank you, Mr. Chairman, Ranking Member Brady, for hosting this hearing today on substance abuse, suicide risk, and the American health system. As I explained at this committee's hearing a few weeks ago, our country is facing multiple crises. We must look at what has worked during the COVID-19 pandemic to address those challenges and issues that remain. We have data to prove that shutdowns, lockdowns, and social isolation have detrimental long-term effects on mental health and overall well-being. From vaccine mandates on our fragile workforce to a growing border crisis that has invited over 10,586 pounds of fentanyl to our communities. The Biden administration seems to only create one crisis after another, and American families are hurting. Given the current crisis in Ukraine, it has never been clearer that we must protect our country and its borders from the dangers abroad. In 2019, China fulfilled a pledge to the United States and placed all forms of fentanyl and its analogs on a regulatory schedule. Nevertheless, China remains the primary country of origin for illicit fentanyl and fentanyl-related substances trafficked into the United States. When you introduce an influx of deadly drugs to vulnerable communities of isolated and depressed individuals, you create a substance abuse crisis, economic crisis, and suicide crisis. As leaders, we must come together to focus on how to save our fellow Americans from this fate. On a national level, the Southwest border crisis is creating opportunities for cartels and other criminal organizations to increase the flow of illicit drugs, including fentanyl, into the United States. The border crisis devastates families and places Americans out of jobs. In my home state of Oklahoma, the Oklahoma Bureau of Narcotics said fentanyl-related overdoses increased by 157% from 2019 to 2020. They say this spike will only continue. In addition to the drug crisis at our southern border, our nation is also facing an unemployment crisis. Unfortunately, psychiatric reports tell us over the last 23 years that economic hardship increases substance abuse based on state annual administrative data, showing a correlation between welfare recipients and substance abuse issues. This is something, unfortunately, I can connect to personally. Growing up in poverty on welfare, I witnessed firsthand the brutal cycle of poverty and drug abuse. Addiction traps a person in poverty and makes it a very hard time to break free. It's about time that we reform our welfare system to also provide support for Americans facing economic hardship, whether this be in the form of support from our community or faith leaders. Allocating money towards more expensive public health programs is not what this country needs right now. The last thing Americans need are higher prices at the gas pump and the grocery stores. One major tool that overcomes accessibility and effectiveness barriers to address substance abuse services and mental health treatment is telehealth, or I prefer to call it virtual health. As the COVID-19 public health emergency limits treatment options, telehealth shows that the use of these disorders has helped over half of our nation. Data shows that nearly 80% of Americans say COVID-19 showed the extent to which more teletreatment options are needed. As I reiterated before, it's time for us to make virtual health flexibilities permanent. We need to figure out how much to pay health providers for virtual visits and come up with a plan to pay for those benefits without bankrupting the already financially unstable Medicare trust fund. Substance abuse, mental health disorders, and suicides can be prevented in our country if Americans have access to the care they need, not only during the pandemic, but during all times of needs. Ms. Halsey, thank you for your testimony. In your remarks, you mentioned substance abuse programs that target parents of children on welfare. Could you tell us if there are any states or local communities leading similar mental health programs for people who are on unemployment programs?
That's a great question. I'm not aware of any states or communities that connect behavioral health services with unemployment recipients, but I can check on that and get back to you. I do agree, though, that any of our vulnerable communities, and when you have financial hardship, this can increase both stress and anxiety, as well as our reliance on alcohol and other substances as our coping mechanisms, which is pretty, unfortunately, consistent across our counties throughout this country. So I think having safety net services for anyone who's vulnerable is really an important part of the solution.
Ms. Halsey, thank you for your work in this area. Thank you for your comments. Mr. Chairman, I yield back.
I thank the gentleman. Let me recognize the gentleman from Nevada, Mr. Horsford, to inquire.
Thank you very much, Mr. Chairman. I appreciate you holding this critically important hearing as a continuation of last month's hearing on America's mental health crisis. I want to thank our witnesses for reiterating just how dire our nation's mental health and substance abuse crisis is, and for sharing their expertise. Many people across America are facing unprecedented challenges, whether that's the onset or exacerbation of depression and anxiety, or hurdles to access to health care services to address these problems. Rates of mental illness, such as depression and anxiety disorders, have skyrocketed since the beginning of the pandemic. And as we all know, drug overdoses hit an all-time high in the United States between May of 2020 and April of 2021. While Congress has made behavioral health services more accessible during the COVID-19 pandemic, some of these provisions have expired, such as the CARES Act provision that allow high-deductible health plans to cover telehealth services. I worry what impact the lapse of coverage will mean for those who have relied on those health care services over the last 2 years, and I look forward to working with you, Mr. Chairman, and this committee to make sure that we provide that coverage in future legislation. Now, I've been listening to some of my colleagues on the other side, and I do want to make one thing perfectly clear. There may be a correlation between economic conditions such as poverty, but that is not the cause. And if we really want to help our fellow neighbors and family members who suffer from substance abuse and mental illness, we should avoid placing blame particularly on efforts that are trying to eradicate those challenges. One example would be support the child tax credit that has actually lifted 50% of children out of poverty, for example. Now, more than 100,000 Americans died of an overdose in the last year. The tragedy of this enormous loss of life is compounded by the fact that it is almost entirely preventable. According to the CDC, the state of Nevada experienced a 30.4% increase in overdose deaths between September 2020 and September 2021. This is almost double the nationwide increase. Medications for opioid use disorder reduce mortality from drug overdose by as much as 50%. Yet, because of outdated federal regulations, only about 11% of Americans with opioid use disorder receive these medications. Ms. LaBelle, what specific actions can Congress take to expand access to this life-saving treatment?
Thank you, Congressman. So I think there are a couple things that are before you right now. There's the MAD Act as well as the MAID Act. And the MAD Act would eliminate the requirement for someone to go through, for a provider, to go through an 8-hour or 24-hour training before they can prescribe buprenorphine. And then the MAID Act also has provisions that would increase the training that needs to be done so that more healthcare professionals, nurse practitioners, doctors understand addiction treatment. Because we have a real problem not only with medical school not teaching about addiction, but we have a number of healthcare professionals who not only are not sure how to identify whether someone has a substance use disorder, but they also don't really know where to refer them for treatment. So those are two pieces of legislation that could be done quickly.
Thank you for that response, and I'll have my staff look into those options. Quickly, on the topic of preventing suicide, America has the highest suicide rate of any wealthy nation, nearly double that of the UK. It is the second leading cause of death in the U.S. for individuals ages 15 to 24, and the risk of suicide increases significantly after 65. Dr. Metzel, your research touches on social and structural determinants of health, mental health, and suicide. So what are some of the ways we can rebuild our mental health system to ensure those in crisis have access to key resource and treatment?
Well, very quickly, I realize the time is short. First of all, again, suicide is what are the resources available to someone who is contemplating suicide at that moment? So something like a national suicide hotline is a brilliant idea. And how can we expand those immediate resources for people who are in moments of despair? And then also, as we're saying, how can we not defund but refund things that build social capital, things like education, the ability to create social networks, job training, all of these factors. These kinds of things make people feel connected, and they give them a pathway out of the kind of despair that leads to suicide.
Thank you so much. I yield back.
Thank the gentleman. Let me recognize the gentlelady from West Virginia, Ms. Miller, to inquire.
Thank you, Chairman Neal and Ranking Member Brady, and thank you to all of our witnesses for being here today. The topic before our committee today is devastating. I have seen it firsthand in my home state of West Virginia, how the opioid epidemic deeply impacted our families, our children, and our communities. I must also point out that Mr. Arrington, Dr. Ferguson, Mr. Estes, and Mr. Hearn all alluded to the difficulty we have with drugs coming over our border and how important it is that we secure our border. In the face of the immense sadness and despair that I've seen in my community come together in amazing and inspiring ways, we have so many facilities, programs, and individuals who have risen up to address the epidemic and to help find healing for patients and their families. One of these places is the Lotus Recovery Center located in Boone County in my district. They utilize an evidence-based approach where they provide a wide variety of services, including cognitive behavioral therapy. They also have a case management program where they focus on the social determinants of health, such as housing insecurity, food insecurity, workforce issues, and educational development. They ensure that patients not only heal while they are in their centers, but also that they have the tools to remain sober once they leave. I am thankful for all the work that they do. We are 2 years into this pandemic, and as a result, we have seen an increase in the drug overdoses. Thanks to historic investment from Congress in the SUPPORT Act, I hope that as we emerge from this pandemic, we get right back on track in addressing the substance abuse disorder. Ms. Halsey, first I want to thank you for sharing your story, and I am so sorry about the loss of your parents. In your testimony, you discussed the dangers of fentanyl. As we all know, West Virginia had the largest number of fentanyl deaths per capita in 2020. Can you discuss the changes in how fentanyl is presenting itself in the country? For example, we're now seeing it in counterfeit pills and even in marijuana.
Thank you so much for your kind words. The fentanyl adulterants are changing a lot of this space. So many individuals with different types of substance use disorders now find fentanyl in their supply. So you have individuals using sedatives or stimulants who are not expecting to take opioids, who have very high doses and fatal doses of fentanyl there. So it's high risk. It is scary for patients and families. We need to be able to address this and keep our patients safe through things like fentanyl test strips. We need interdiction efforts to help us reduce the amount of fentanyl in our supply. And we also need to make sure we have treatment and safety net services. You might need multiple doses of Narcan or naloxone to reverse a fentanyl overdose just because of the potency. You might need to have modifications to your treatment plan, ensuring that we engage people in medications for opioid use disorder who are struggling because of fentanyl. So it's affecting, I think, every aspect of the addiction crisis. And I think we need to double down because the loss of life is just, the numbers and what's happening in the community is really hard.
Well, you mentioned how 78% of the patients have a family history of substance use disorder. And as we all know, rates of substance abuse grew in the pandemic. Children whose parents have substance use disorders are at greater risk in the home. As Congress looks to address this issue, what effective methods can Congress consider to provide support for the children and adolescents whose parents and caregivers are struggling with addiction?
Absolutely. The risk of, we know that genetic factors add to your risk of developing an SUD, but it's not simply one gene. It's this complicated constellation of genetic factors. And we need to make sure that we are supporting families who are struggling. We need to look at all SUD types. Of the 20 million people struggling with addiction today, 15 million of them have an alcohol use disorder. So while we are experiencing overdoses and so much difficulty in the opioid space, I think we need to look at the big picture. And there are amazing programs that work through child welfare services, that help keep families together and give parents the treatment that they need. I would have loved to have had something like that available to my family before I went into foster care. So how do we take what we know works and then take it to scale? That's really, I think, our challenge right now.
Thank you so much. I know I've already used up my time. I yield back.
Thank the gentlelady. Let me recognize the gentlelady from the Virgin Islands, Ms. Plaskett, to inquire.
Thank you so much, Mr. Chairman, and thank you for this hearing. I think the witnesses have been absolutely incredible. I want to thank you for the staff for putting this together. This has been absolutely informative. I've been so grateful to members on both sides of the aisle who have really asked some tremendous questions and the information that we've been able to glean from this. We focused on issues of substance abuse disorders, overdose death, and suicides, which are in fact a huge epidemic in this country. And taking a deep dive on these issues, looking at how the rates have increased exponentially over the last decade, and the work that's being done to try and stem the tide of something that seems to be just absolutely overwhelming. The need for greater awareness of how federal policies have long stigmatized and marginalized treatment for those in need, of course, people struggling with substance use disorders and suicide ideation into shadows. I'm so grateful for you, Mr. Chairman, and the other members of the committee for shining a light on this throughout the country and even within our own lives. I have a couple of questions here. One of the things that I noted, however, and I don't mean to throw any cold water on the care and the concern that many of the members have expressed in this discussion. But there has been a stark, glaring absence in some of the discussion that I've been hearing. I know that one of my colleagues earlier in the discussion talked about the Support for Patients and Communities Act that was passed in 2018. He mentioned also the Comprehensive Addiction and Recovery Act of 2016. So much of this legislation is related and focused squarely on opioids, squarely on prescription drug addiction, which is absolutely necessary. It is something that is going out of control within this country. But I cannot not notice the fact that we have not given the same kind of discussion and the need to, the ability to call individuals who are addicted to prescription drugs as having a mental disease, and those who are addicted to crack cocaine or heroin in communities of color as being criminals and drug addicts. My colleagues across the aisle are unwilling to expand prescription drug and support for individuals who are addicted to crack cocaine, addicted to heroin, and the ravage that that is doing in those communities as well. I have had several cousins early in the beginning of the crack cocaine epidemic, early on during the AIDS epidemic, die of either crack cocaine or heroin addiction that precipitated them dying in the early 80s from AIDS. And so I wanted to ask these practitioners, what do you think has transpired over the last 30 years that is now allowing us to call prescription drugs addiction as a mental health addiction, a disease? And those individuals who are addicted to crack cocaine, heroin, and other drugs, which are predominantly in African American and people of color communities, still as criminals.
Thank you for, this is Dr. Chapman. I'd like to answer that. In my presentation for the Office of Minority Health about 3 years ago, I emphasized the historical difference of Africans in America. We started with slavery. We went through the post-slavery era of Reconstruction, then the Jim Crow era with hangings and segregation. So I showed slides that showed that this is a continuum, and it really hasn't changed into the post-civil rights era. So our community has always suffered from post-traumatic stress disorder, and it's been intergenerational. It was just ignored.
Thank you. Can I have so little time. If anybody else wanted to offer any thoughts on this?
My research shows that that when you call something an addiction versus criminalize it, of course, it leads to different outcomes. And so an addiction leads to support networks, which are super important, whereas criminalization of something leads to the prison pipeline, basically, or things like that. So this has real consequences. And so we really need to broaden the definition of addiction and also the alternatives to ways out of it for people.
So in closing, I would just ask that my colleagues across the aisle show the same empathy that they have for prescription drugs and opioids to the ravages that are occurring in my community from crack cocaine, heroin, and other drugs that you are insisting on criminalizing. I yield back, and thank you so much, Mr. Chairman.
Thank the gentlelady.
Let me
Thank you. Let me recognize the gentleman from North Carolina, Mr. Murphy, to inquire.
Thank you, Mr. Chairman, and thank you to all the witnesses who have come out today. I appreciate all the hard work that you guys do in a very, very difficult environment. This is personal to me. I've treated for patients for 30 years, many of whom have substance disorders, and it makes their treatment for cancers and everything else exceedingly more difficult. It's also very personal to me, where I've known 9 young men, kids that were in my kids' school, church, scout troops who have died from overdose. So this is a very, very personal issue to me. The pandemic obviously presented many disturbing societal and challenges and implications to public health that I believe deserve some retrospective analysis. Yet, as many instances with the Biden administration, many of these crises have been self-inflicted and worsened
by politically motivated decisions. The unnecessarily prolonged lockdowns brought stress, uncertainty, and isolation, which served as catalysts for suicidal ideation and substance abuse. Public health, economic and mental health deterioration driven by the isolation, the depression, and subsequent substance abuse have regrettably led to many committing suicide or accidentally overdosing. One witness pointed out that building societal structures is a good thing, and I believe in that. I believe it is beneficial. But I'll submit that this problem with societal structures will be traced back now to 1965 and the creation of the Great Society programs where the destruction of the nuclear family started. When we closed businesses during the pandemic, schools, clinics, churches, people sunk into a very, very dark place. And sadly, political science overtook medical science and heavily exacerbated what was already a bad mental health crisis. Suicide attempts among girls aged 12 to 17 rose more than 50%. You can see the despair on the youth. You go out and look at the walls of the kids who've painted pictures for us, and you see that what was normally a happy picture oftentimes now has turned very, very sad. We need to move away from this. We need to play our part as parents and leaders of the community. You know, we as physicians took leadership in the opioid epidemic, and we stopped overprescribing of opioids. We really took a great lead in this 5 to 8 years ago. Sadly enough now, of addiction now is with illicit fentanyls, and we know that 80% now of those come across our very, very porous southern border. How do we know that? Seizures are up 134% in 2021, totaling 11,000 plus pounds, which is enough to kill every American 7 times over. But how do we know that that's not enough? We know that's not enough because 100,000 Americans died in a 12-month period. Even further, the price of fentanyl on the streets have dropped 50%. So the southern border has a very, very large part in exacerbating this crisis. Now, fentanyl is the largest killer in age 18 to 45, as multiple of my colleagues have said. Overdose deaths have increased to 25% in North Carolina in this past year. We need to do something about this, and I appreciate the work that you're doing. Ms. Hulsey, my deepest condolences to you and sympathy upon the loss of your parents, a tragedy. Let me ask a question of this. You spoke of the need to enhance the substance abuse use disorder treatment workforce in your testimony in Section 71 of the Support Act, which was a loan repayment program established to incentivize students to enter the profession. Are there any avenues that you feel could enhance movement to this program to provide personalized care to different geographic regions which require a diverse set of needs?
Thank you so much for highlighting that. I do think that there are enhancements, whether it's more loan repayments, it's incentivizing more bachelor's and master degree licensed positions, kind of going upstream in the sort of workforce place, and how do we have more people entering the addiction workforce, engaging high school and college students to talk about this as a priority. And then even as we incentivize and bring people into the space, if we don't pay them the same as other healthcare specialties, how do we retain our workforce? There's an amazing provider in Illinois, and he was sharing that the reimbursement rate for the case managers and the counselors he works with is minimum wage. It's $15 an hour. So you're working with clients and putting them in a manufacturing position at $30 an hour when you're making half that. So we need to address the pay disparities and make sure that we can keep our workforce focused on this growing health condition that needs to have a whole host of clinicians ready to treat our patients.
Great, thank you. Again, I'll go back to the fact that we do need all of the armaments ready to help us in this, but I'll go back again and again and again, and I'll talk about the destruction of the nuclear family and how it's led to so many of the societal ills that we have now today. I'll just end because I agree with my colleague across the aisle about the criminalization, some of addictions in different forms. Addiction is a disease. It changes your brain chemistry. Period, point blank. I don't care if it's prescription opioids. I don't care if it's heroin or crack cocaine. It changes your brain. And I do agree. Incarceration for individuals, yes, it should be done for people pushing, but I believe in our prisons, we really need much more of a mental health intervention on those individuals, because the recidivism rate for individuals who have mental health disorders and addiction to opioid and these other substances is not miraculously, is tremendously high. So interventions really within our criminal justice program are necessitated at this point in time. Thank you, Mr. Chairman. I'll withdraw. I'll yield back.
Thank you, Dr. Murphy. So as we about the southern border, we all acknowledge, based upon the testimony here today and the commentary that was offered, this is a supply and demand issue. It has to be treated as such. But I think, as Dr. Murphy just indicated, we don't want to miss the point that substance abuse is a mental health disorder and a disease. It's a disease that existed before drugs came across the border, and it will persist even if we are successful in closing down the border. We need to stop the flow of dangerous drugs. Everybody acknowledges that, and the Biden administration is taking steps to do so. I want to enter into the record a list of actions taken over the last year. In 2021, Customs and Border Patrol seized twice as much fentanyl as they did in 2020, 4 times as much as they did in 2019. This issue has spanned many presidents, Democratic and Republican administrations. It's a very complex issue. But we learned a lot because the witnesses were superb today. The best way to fight substance abuse disorders is to work to eliminate the risk factors that cause addiction in the first place: poverty, instability, race, criminalization, among many others. Preventing addiction is the first and most ensuring robust access that we need to evidence-based treatment that will support our priorities. I stand committed, as we've heard some pretty good, encouraging terms today, to pursue this objective. Millions of Americans and their families know of what we speak. Everybody in this room today knows somebody, has a family member or an acquaintance, a neighbor down the street that has had this issue. And I think the best way to address it is to continue to understand that we need to treat the disease while obviously addressing the supply issue simultaneously. Witnesses were terrific. Please be advised that members have 2 weeks to submit written questions to be answered later in writing. Those questions and your answers will be made part of the official record. With that, the Ways and Means Committee stands adjourned.